Now in his 70s, Professor Khama Rogo is the sixth of 8 children, including the late Orie Rogo Manduli, his eldest sister. He was named after Chief Odera Ingem, a chief who encouraged education. Back then, the Anglican Church didn't allow African names, and children upon baptism were required to take up English names, for which his father was opposed to. Luckily, there were 2 African names allowed: Kwiga Agri, a missionary and teacher from Ghana, and Khama, the Botswana king who welcomed missionaries in Southern Africa. And as such, he was named after Khama.
You must know you are in game. You are in game. And game is one of the stronger clans in Lowland. Yeah. So Chief Odera, who is credited with encouraging education and everything here. So that name, Odera, is a chiefdom of that. So maybe he thought that I could rise. But, yeah.
Do you think you've lived up to those, actually 3 names, the Khama, Odera, and Rogo?
I believe to a large extent, yes. Yeah, without professionally. Yeah, not the political royalty, but professionally, I think that I'm there. I think I'm there.
Being a child of teachers meant that they grew up guided by 3 principles: work, learn, and pray. He schooled in Tomboya High School, Maseno School, and Duke of York, now Lerana School, for his A-levels before pursuing medicine at the University of Nairobi in what was Kenya's 6th medical school class.
What inspired you to do medicine?
Okay, I think that it has to start from where we were. We lived in Kaloleni. So I'm a Kaloleni boy. And Kaloleni, which is now called Kaloleni slums, the word slum didn't exist then. So it was just a place where African lived. And Kisumu was a perfect apartheid system. Africans were living in Kaloleni, Indians had their place, Wazungus were in Milimani, schools were separate, Arabs were in the Manyatta Arab in the mosque area in Kisumu. They even went to their own schools. So we were not mixed. Manyatta and Nyalenda and Kondele were not part of the city. Those ones were called African reserves. So ukimwambia mtu kwamba wewe unaishi kwa reserve, you reach in the reserves. Just like this game reserves, there's African reserves. Okay? So that is where we were born. And Kaloleni then was a mixture of everybody. Tribeless, faithless. It was a mixture of that. And that's where we were born, and we grew up in that. In that lawless setup, the thing that distinguished family was the strictness of the parents. Because you'd mix everywhere, play truant, not go to school, but strictly that. And my parents and other parents, we have a lot of very successful people who came out of Kaloleni, were known for that strictness. Mwalimu, follow the rules. Sunday school, go to Sunday school and that. So we grew up in that environment where you are mixed Africans speaking all languages, but you are third class. Indians are second class. Indians and Somalis were together. And then the Mzungu is up there.
First class.
So we grow in this environment in which even for you to live in Kisumu, the town itself, you needed a pass if you didn't dwell there. So people from Manyatta and Nyalenda, to come to town, you needed a pass.
Wow.
To spend a night in even Kaloleni visiting a relative, police could come in the middle of the night, white inspector with the dogs, knocking the door to see how many people have slept in this house. And I still recall, because we used to sleep, many of us, on the floor on the mat, the white man knocking, and if they knock 3 times and it's not open, they kick the door open. And they come in to just count how many people are sleeping in there. So you as kids, you'll be there, you're waking up with these dogs that are sniffing, the Alsatians and so on. So that is what we grew up in.
So how would they know that there's an additional person? Did they have
It
like
was
a record?
random.
Did they have a record to know that
Yes,
this
because the
house...
people who are in there, they would have, yeah. So we start then going to school. Primary school, we are all walking there. No shoes at that time. And you start learning. And you start learning about the explorers, the David Livingstone. Yeah, that David Livingstone was particularly because it was Dr. David Livingstone. Yeah. Then you start being exposed then to the health services there where there were dressers, not even clinical officers, but they had white clothes, and you go there and you start admiring these people because they're so clean, they're white, and they can tell you anything. Open your mouth, and you open
And
your
you
mouth.
open.
Yes. So that is an interest that you start having. Then we start playing sports, and for some reason, I was always very good at sports. I played football all the way to Gor Mahia.
Oh.
Yeah, I was always a team doctor. For some reason, if somebody was injured, I was always a team doctor.
That
But
was even before you became a doctor.
no, this was primary school. Yes, but something happened sometime when I was in high school. This area of game is famous for academia and doctors. And in fact, Magoa's home is just nearly here. There, you'll get I'll watch down there. You can see who's who. Arambo is down there. Yes. So there was one Dr. Ochieng, one of the older Makerere guys, who was one of the first African private practitioners in Kisumu. And my father sent me with a letter to him because my father was the chair of the game people in Kisumu. So when I went to knock on his door and they opened and I went in and received the letter, then he asked me, "Oh, young man, you're in school?" "Yes." "You're in what?" And said, "I've just entered Form 1. And said, "What do you want to be?" He said, "I don't know." Then he said, "Yes, I can see in your eyes. Be a doctor like me." Okay? So people will not call you Mr. anymore. Be a doctor. You hear that? Yeah. And from that time, it just entered my head that I would want to be a doctor. And luckily, the passing of exams was not a problem. And there you are. And then we are in this school system at that time that it was really merit.
Yeah.
Yeah, that your exams, O levels, A levels, they're all marked in the UK. You wait to read the newspaper.
Oh.
Yeah, it was in the newspaper that you buy newspaper that day to see whether you had passed, which grade you had passed in, and so on. So there was nothing like your uncle or your brother who's influence exam. And then you see you're in Division 1. Then A levels, you have 3 principals and a subsidiary. And then you just sit there and wait for a letter to come. That letter tells you, okay, you're now going to A levels in this place. Then university too, a letter just comes in the post office that you're in the University of Nairobi, medicine. And you park and you go. And you arrive there and you meet other people who have passed well, and that's it. So the impetus was seeing what was around me, the encouragement of Dr. Ochieng, and most important, I think I was bright because in high school, my English teacher, Mr. Taylor, in literature and English language, always thought I should be a lawyer. But later on, I came to realize that actually there's something that is tougher than being a lawyer. And it became medicine. Yeah. I think it would be a walk in the park if I went into law school. It was not challenging enough. Yeah.
So had you not met Dr. Ochieng, do you think you would have ventured into any other career?
Law, probably. Law was the other alternative. And in my O-level results, I had 1-1 in all those things, in English, in history, and that would have taken me easily in that. But then, at that time you choose, when you go to all A levels, you choose whether you're doing sciences or arts. So I chose biology, maths, and physics going into that, instead of taking English, history, and geography, which have taken me to the other side. Yeah.
So when you joined the University of Nairobi, 1973, did you find medicine to be as challenging as you say it was, or it was still a walk in the park for you?
Tough. It was tougher than I thought. One thing is that the 80 or 83 of us were the best students in science, not only in Kenya, but in East Africa, because we had an inkling of Tanzanians and Ugandans. Although we had separated from Makerere, still they took in students there. So you can imagine that if you are students, you are the best. You've all been number one throughout. And then you come into this place where you find you start looking for your name after a test has been done. And you're used to checking up there and you don't find it. And you find it's the middle or in the lower, yes.
And you're not used to that.
So all of a sudden you realize, you mean this is it. The second thing, brilliance, total brilliance, really, really bright kids. The second thing was, I was also a sports person. So when I went to university, I was still playing Premier League football for Kisumu Hot Stars. So on Fridays, I would be on the overnight bus to come to play on the weekend league at Kisumu Stadium. I arrive in the morning on Saturday, sleep. In the afternoon, we jog, and we are at Kisumu Stadium. I'm part of the team. Yeah, these guys, Bobby Ogola and so on, those are my teammates. Yeah. Then at the end of the match, you are celebrating, you sleep. The following day, you take a Kamba bus. It was a Kamba bus then, not Easy Coach. And 1 o'clock, 7 p.m. you are in Nairobi. And then on Monday you are in class. So your colleagues who are in Nairobi probably are enjoying but are also studying. You are a footballer. So mixing those two things became tough. And our professor of anatomy, Professor Mungai, in one of the class, he used to teach on the human structure and walking. He comes to class in the morning and he has a newspaper. So he sends a newspaper around to the students and say, look at the back page. Who do you see?
That's the sports page.
Yes. And we had just played Kenya Breweries in Kisumu. And the photo there was me in the air heading. And Winzi Mwakolo was a Kenyan star brewery. So my photo was there. So people look and said, hey, this is Khama. So he takes it, but you know why I'm showing you this, guys? Medicine is tough. You don't mix it with anything else. So tell your friend to choose between playing around with the ball and being a doctor. Apparently, Professor Mungai had been a sprinter and an athlete in Makerere. And because he mixed the two, he had to repeat several years. So his experience was that you don't mix sports and
And
medicine.
medicine.
You go to medicine, you dedicate it to medicine. So this thing made a lot of people, young people who went into medicine, who are sportsmen, stop doing sports. And I know some of them. The late Dr. Olema was a Kenya national team footballer. He was 3 years ahead of me. He went there, he had to stop football. It's only later, much, much later, that the mixing was allowed. And that is when
JJ.
William Obwaka, Dr. Bwaka, and Masiga,
JJ Masiga, yes.
JJ Masiga. So they came later when that one was allowed. So it was tough because the first year with anatomy was tough. You had to cram and cram and cram. There was no way out. So that was very, very tough. Embryology, extremely tough. How they say. And then, of course, you had biochemistry and so on. Yeah.
And
The first 2 years, I think, in medicine are the toughest. Yeah. So it was tough, but it was rewarding because it was challenging. You just had to discipline yourself and be there. Remember that we went into university at a time when they used to be given an allowance. Boom. And when people got that, guys got drunk and so on. You, as a medical student, you're in the main campus with everybody. All your colleagues are doing the others. They are enjoying. You got to create your time and make sure that you're up to that. So you could enjoy, but the moment you go to Chiromo classes, then you see how far you're behind. So that competition, the toughness of the amount of information that you have to learn, made it tough, but rewarding.
Okay. And upon graduating in 1978, where did you start your practice from?
Interesting thing that my years at the university were also very colorful because of the students' activity. I was a student activist too. So I was chairman of AMSUN, the Medical Students Association, and I was also vice chairman of the African Medical Students. So when I dropped sports, I came strong in activism. So I became our class leader, and I'm still the leader of that class 50 years later.
Wow.
So when we celebrated our 50th year last year of class, that went in 73, I'm still the undisputed class leader. So it is not by election and it is not by rejection, but that's it. So that one also made it tough because I have some very interesting things on my interaction with the teachers, with the university system, and so on. Because it was during our time when the ugly head of tribalism started coming into the faculty. And the removal of Professor Giambo from chairman of Department of Medicine happened then. And I was the student leader then. And we boycotted classes because we did not think that that was academic. Professor Giambo had given an inaugural lecture at Gandhi Hall on the title was The Pursuit of Excellence. If you know Josephine Ojiambo, the daughter, you ask her to give you the father's paper. Because that was a time when they started questioning the criteria for being a professor. And during his 25 years of experience in medicine, the pursuit of excellence, he questioned the criteria that was coming in then. It was no longer excellent publishing and research. It was ethnic. At the end of that lecture, which was professorial inaugural lecture, that night, the vice chancellor, Professor Karanja, who later on became the vice president, ordered that he be demoted from chair they removed his books from his office at night. And when we went for lectures in the morning, we found his books were in the corridor. He's no longer chairman. He has no office. They are in the corridor. And somebody else had been appointed. Asked why it was said that he said some unpalatable things about his colleagues. That there are some people who are becoming associate professors with one publication or two publications, which was true.
Which was true.
So some people called Karanja that afternoon in the golf course in Udaiga. And Karanja ordered that the guy is to be dropped. Hilary Ojiambo. So we decided that we were boycotting classes because we said, no, there was nothing criminal that this guy said. We all enjoyed, everybody applauded. The dean was there and the whole faculty was there. So what is the problem? So I was summoned as the chair of AMSON to the faculty board meeting. Why were students boycotting? And I said that clearly. That is because I think that Professor Liamba has been treated badly and that all of us who are there find absolutely no fault in what it said. So unless you reinstate him, we are not going in for lectures. This was followed by 4 days of boycott with the board meeting every day, and I was the only student
In the meeting.
in the board meetings. I think I was in the final year then, and I had very, very rough time with my colleagues because the ones who were sent the complaints were also my professors, and I had to tell them that's this was not about you as an individual. It's about the character of our institution. And as students, we take this stand. 3 times I was sent away and told to go and tell my students, the students to go back to class, and I refused. So they threatened me with not being able to sit my final exam, and I said, no problem. But we stood by what we did. They never reinstated Ujiambo, but we never recognized the professor who was put there to chair that. So we then finished medical school.
So what then made, after the 4 days of boycott, what made you go back to class?
Because Ujiambo came and talked to us.
Okay.
And he told us, thank you very much, students. Your future is more important than mine. I have made it. Any university in the world wants me. So continue. What you're standing for is right, but you must also know that you have a future. That's when we went back.
Those are powerful words.
Yes, they were. So we finished medical school, and in those days when we finished medical school, KMA would have a party for you to welcome you to the fraternity. And you would go to Afia House. First of all, you go on the blackboard, on the board, school board, to see if you're passed. Then you go to Afia House. By the time you reach Afia House, you'll find they already have a list of your posting for internship. It was now, initially, internship was only done in Kenyatta Hospital because that's where you had all the consultancies. But they started moving it to the provincial hospitals. So they had started moving people to the provincial hospital. So you'll go there and you'll be told you're posted to Mombasa, Coast General, Kisumu, or Kakamega, or Machakos, or Nyeri.
Rift Valley.
Yes, and Nakuru. Yeah. So those ones were that. At that time, Eldoret was a small hospital, so there was nothing like Eldoret. It was Nakuru. So you go there, and you see there, and you're given a letter. And with that letter, you are also told to pick up your ticket. For Mombasa, it was a railway ticket. So all of us who are going to Mombasa, I think that there was 14 of us, the biggest number ever to go to Mombasa. We got our ticket, railway line, chukua gari, you go and you arrive in Mombasa. Then you make your way to the provincial hospital. You meet the hospital superintendent, Dr. Kulumba Mwangala, and he gives you a talk on internship.
Had you ever been to Mombasa before that?
I had been to Mombasa before that once because my brother, Engineer Rogo, was the chief port engineer. He's the first African port engineer in Mombasa. So during my elective year, fourth year, at the end of fourth year, I went to stay with him and did my electives in Mombasa. Yes. So I had been to Mombasa before he was there. So when you arrived, you had been told that the moment you arrive in Mombasa, they'll take care of you. There'll be an intern's mess where you'll stay and you start working. So when we arrived, we found...
Sorry, was that immediately after your exams are out?
Yes.
Oh.
Yes.
Okay.
Graduation, you'd come later
to
graduate. Your exams are out, you go.
Things have changed a lot.
Yes. So you go directly. Within the week. Yeah. So we go there and we found that the interns who were ahead of us were still staying in the interns' mess because they had now been posted out to the districts. But some of them had not left because after internship, you would be posted to the district. And when you go to the district, you'll find your one doctor. So the interns are not left. So where do we stay? That was a big question. We were enthusiastic, we wanted to work. And we were told, oh, you'd have to wait for 1 month to give this. But they said, where do we stay? And the activists that we were, we said, no, we must stay somewhere. We're going to work. Because we actually started work that same day.
After the talk?
Yes, after the talk. You're posted, you're in pediatrics, you're in obs-gynae, go. These interns who are there are going to hand over to you. So there was handover by these interns because you're now the guy who's going to be carrying, they're now medical officers. They won't be called at night or anything. The question that where do you stay? So the first night, we slept around in benches on the hospital. You remember we had our small suitcases, nowhere. The following day, we said, no, this won't work. So we went to Kulumba's office, and Dr. Kulumba told us, you know, Nairobi sends you to me. I'm not ready. Mine is to give you work. If you have a problem, go to the provincial medical officer of health in the city. That was a Goan called Dr. Fernandez. So we all go together as a team and we go to Dr. Fernandez and we introduce ourselves and said, yes, I know you people are here. They say we are here, we have started working and we need accommodation. They said, don't you have anything in the hospital? We tell them we don't have anything. They said, okay, go back to work. We'll see what to do. We went back to work. Nothing happened. We marched there the following day and we said, we are not coming out of this office. Just give us accommodation. Luckily, that same morning, the DMS, Director of Medical Services, that's a post that they now call DG, was in town. Kenyatta used to do several months in Mombasa, during Mombasa show and so on. August, September, Kenyatta, the president, would be there, and most of his cabinet would be that side. Then December onwards, he would be in Nakuru. So most of the cabinet would be around Nakuru, and then in between it would be Nairobi. Now, this Director of Medical Services happened to be the only Kenyan who has ever held the following post: DMS, PS, physician-in-chief, and physician to the president. One person. And his name was Dr. Eric Mngola from Taita. And Mngola used to teach us as one of the honorary lecturers, because at that time, all the senior government people would also teach you. So he knew us very, very well. We were doing ward rounds with him, clinics and so on. So when he came and found us in Fernandez's office, he said, "Hey, my boys," that's what he used to call that. "What are you people doing here?" So he told him, "We came here to get accommodation." So, "Accommodation for what?" "That we have all been posted here." "Oh, so you are in Coast General. You know this is my province.
Yeah.
So I want you people to be excellent doctors." So he called Fernandez and told Fernandez, "Why are the boys here and the girls? Why are they not in the..." I said, "Sir, they're still looking for accommodation." He said, "No accommodation?" "Yes." "Why?" We explained to him. He asked them, "Give them imprest." Each one of them. And to cover their nights until you get houses. And the boys, the imprest is given to you. Make sure that you bring the receipts of wherever you live until that thing is done. 2, even if you have no house, but every night you go to the nightclub, bring the nightclub receipts to show that where you go to. So in the meantime, I will arrange for you to get a hotel somewhere where you can all stay together. Now, before I forget, it took about 2 weeks for that to happen. So my brother, who had a house in Kizingo, told me that if your friends have nowhere to, you people come. So all the boys, my brother gave us one room. So people who are on call would go to hospital. The ones when he knew would sleep in this room. So actually we stayed for 10 days in my brother's house. Yeah. The girls stayed with the mother of Mary Mjomba, who was one of our classmates, Dr. Mjomba, who was Maendeleo ya Wanawake official. So we lodged in those 2 places. Then Mngola came and got us Tudor guest house. And he also ordered that we be given a van that would ferry us from, because the intern's mess was in the hospital. So it would ferry you all the time. So we did 1.5 months with imprest and with a van taking us to hospital every day. We were proud workers. Never missed a ward round, never delayed anything. We were disciplined.
So without Mngola's intervention, what would have happened?
I think that our standoff would have taken longer.
Okay.
Yeah.
You were determined.
Oh, yeah. No, get this from me. If I fix my lens on that thing, I'll reach there. Yeah. So we said we were going to, but we were not abandoning work. We were going to work. You're on call. You are everything as an intern. We said that you have to give us. There's intern's mess. We want to go in there. We went there and found one of our Ugandan consultant gynecologists was also staying there.
Oh.
Yeah, because at that time, during years in medicine, that's when Idi Amin thing disrupted Makerere.
Yeah.
So we had a lot of teachers who came in and a lot of specialists Ugandans who came in. That's an important part of our education, that Idi Amin thing. The loss that Idi Amin created in Uganda was a gain for us here because we got some of the best teachers.
Some of them were our lecturers many years later.
Many years
like
later.
20 years 30 years later, actually.
Yes. So we got the cream from Makerere coming in, and some of them were the teachers of the people who are already teaching us there, because all of our teachers were people who are ex-Makerere, people like Wasuna, Mati, and so on. They're all ex-Makerere. So their teachers were coming on this side. Yeah.
Okay. So is there anything from your internship that inspired you to do obstetrics and gynecology?
Yes, I'd always struggled to find out which was my best side. Was I more of a surgeon than a physician? And I was split between that. The one thing that I knew I didn't want to be was a pediatrician.
Why not?
For some reason, I didn't like the way kids cry, even when you're trying to do your best for them. And then my friend, Professor Bill Wasuna, was into pediatrics right from the beginning. We were very good friends. I'm even his best man. So this struggle brought me to the realization that if you want to be both a physician and a surgeon, go to obs-gyne. Because you'll be doing surgery, but at the same time, you're doing a lot of physical medicine. That was one. Number two, during our medical school years, the infamous abortion ward in Kenyatta, there was a ward that was just for septic incomplete abortion. And the suffering that we were seeing there in young women and girls coming in with that, and then you go to theater, you find the uterus is rotten. I said, this thing, something can be done about this. And then during internship, maternal mortality, I loved saving lives. And I've never seen a place where the lives that you save becomes more immediate than in that, whether it is for the newborn or it is for the mother. She's coming in, bleeding, collapsed, you resuscitate, you remove the placenta. Sometimes it's just a placenta that is retained. And life just comes back to this person. And then there's this baby whom you struggle, cord prolapse, you go do cesarean section, the baby can't breathe, and that's it. So the rewards were very immediate and very real. And then they live to thank you. The thank you from a mother whom you've saved and the baby that's there. Those things just overwhelmed me. And I said that this is why I went into medicine. This is where I went. So reproductive health then became my mantra. That's it. And I've never regretted.
I think that later on, when introducing MVA, you faced a lot of difficulties. Where was that? Because it's potentially life-saving, especially with clinical officers and nurses, if they can, do the manual vacuum aspiration.
Thank you for reminding me of that. That was a battle royal. The thing is that we had this situation. Now I'm coming back to do obs-gyne and I finish and I'm a lecturer. And you have the whole of what we call Ward 6. As a student...
That's in Kenyatta?
In Kenyatta. I did the biggest number of uterine evacuations in one day. 75.
Wow.
Yes, 75. Because the ward is full and it's being filled every time from casualty. And you have to be in theater and these women are brought in bleeding and you do that and out. I did 75 between 8 a.m. and 8 p.m. And I told myself that this is not right. It can't be. The traffic, the nurses who move these people in and out, they're recovering from anesthesia. I said never. So when I became a lecturer with the knowledge about MVA, that's what made me do that. You could actually shorten this journey from ward to theater. You didn't have to have MDs, doctors doing it. It could be done by a nurse in a health center. So decentralize these things so that these people get care faster and closer to home. So I demonstrated this at Kenyatta. And we cleaned Ward 6, which was known for crowding. You had over 100 patients in that ward.
Wow.
Smell, all these sepsis and everything. And it was a place where you only posted doctors and nurses whom you were punishing. So I took that ward and said, I will clean this place. We'll have tea in this ward. Nobody could ever thought of having tea in Ward 6 because of the smell. We'll clean it. There will be no smell. And I did that in 1 month. And changed that with MVA, training people on manual working restriction. We did a side room where we could do the evacuation. They didn't have to go to theater. We did it without anesthesia because with the MVA, the cervix is already open. You simply suck, you don't scratch. So it can be done and the woman walks home. But that success, with all the other things that, because we tied that then to post-abortion family planning and pre-abortion counseling and adolescent health, because a lot of these people are adolescents. And that is where the problem was, that at that time, Kenya was not ready to talk about adolescent reproductive health. Number two, the Catholic Church. So I came face to face with that when my daughter, my last daughter, Paula, was attending kindergarten at Consolata Nursery School. And they expelled her from school at kindergarten because of what I was doing in Ward 6. Yes. Okay. So my wife went to pick her up in the afternoon, and the Mother Superior called her and told her, Mrs. Rogo, don't bring your daughter back to school tomorrow because your husband is doing bad things for this country. So when I reached home, I found my wife there asking me, what have you been doing? What have you done? That your
to
daughter has
expel
been
a kindergarten child.
Kindergarten child. Expelled. What could I have done? So she was keen that I don't take her back. I said, I'm taking Paula back to that school. I said, they'll mistreat her. I said, no. So in the morning, I drove to Consolata. But the superior was there drinking. I didn't even talk to her. Took the kid in. Coming out, she told me I shouldn't be bringing that kid back because she's expelled. I said, how do you expel a kindergarten kid? So I told her that it's okay. I brought her back, I'll pick her up again. So from there, I passed through, I went to university because I was going for my ward round. When I reached the parking there, I'm told that the dean, Professor Buibo, wants to see you. So I go to the dean's office, and Professor Buibo shows me a letter. And the letter is from Cardinal Otunga from the Catholic Church, asking the university to dismiss me, that I was not fit to teach people because I'll teach them bad things. So my kids have been expelled on that side, and this side, they want me. So Professor Bibo tells me, Kama, what are you up to? I said, that you all know, you've thanked me for what I've done in Ward 6. He says, if that's all you've done, continue teaching. We're not doing anything. So rather than go to the ward round, I went to see my lawyer, Oraro and Rechier, to report that my kid had been expelled from school and I will sue the Catholic Church, and that if I'm dismissed, I'll also sue them. Luckily, none of those things happened, and the kid was readmitted. And I think that she still holds a record as the youngest expellee. She didn't know that until a few years back when I was receiving some award. I think the lifetime achievement in health. And I went there and somebody told that story. And she was accompanying me there. So she said, me that you didn't tell me that I was expelled. It's not on my records. I said, well, you are expelled. So my activism in that area brought me into a lot of problems with the church, particularly,
Yeah.
with some political forces that were following the church teachings and so on. But it was fun. It was fun.
So looking back many years later, because some of us, my internship was in 2012. Those are more than 20 years
Yeah.
since introduction of MVA, and it was part of the practice.
Yes.
So looking back to that and what you're able to introduce, how do you feel about it?
It's one of my greatest achievements, and I thank God for that, because I introduced MVA in the whole of Africa. And I became the vice president of IPAS globally, because this thing was a life-saving thing for everybody. It changed the way we manage abortion
Yes.
and removed that.
Yeah.
Same thing in Mama Yemo Hospital in Kinshasa. Those dirty smelling ward. Same thing in Makerere. Same thing in Muhimbili. Black Lion Hospital in Addis Ababa. Same thing. We transformed those things. In Accra, in all the big hospitals in Nigeria. Yes. Same experience. It was, I believe, a mission of passion, but with a focus that this is not the way to do this. Technology is there, and this technology can make women's life better and safer.
And
So
save
one
lives.
of the lessons that I had there, embrace technology. And it doesn't have to be the high things that are taking to the sky. Just this syringe, it's just a syringe. Yeah. And that's it. Moving that thing, first of all, putting it in the hands of the doctor, and then putting in the hand of the nurses. That one has to be a career change for them.
Oh, yeah.
So task shifting was also, I think that's one of the first major task shifting activities that I undertook. The second one was in family planning. Do you know that IUCD, the intrauterine device, and Depo-Provera, nurses were not allowed to do it. It was only the doctor who could do it. And we demonstrated, and we even did papers to show that this thing is as safe, if not safer. IUCD can be put in by the nurse. Depo-Provera, yes,
by
the
the
nurse can inject. And later on, the implant
The
too.
implant,
Yeah.
yes.
So we had to move it to, first of all, convince the OBGYN society. Because, the societies protect their turf.
Yeah. Yeah.
So I had to make presentation to COGS for this thing to be allowed, then demonstrate that it is safe, and it is now common practice.
Yeah.
I asked Professor Rogo how he shifted from basic obstetrics and gynecology to specializing in gynecological cancers, that is, women's cancers.
Together with the reproductive health issues that we are dealing with in Ward 6, the other big challenge that we had was the management of cervical cancer. Because again, cervical cancer was presenting the same way. They come in late,
Yeah.
they're bleeding, they're infected. And in the ward round, we would go there and we say, that's cervical cancer. What do? Call the oncologist, Dr. Onyango, in radiotherapy. That was all. Call him. We go and do the staging. It is stage 3, stage 4. There's nothing we can do. Call him. So Dr. Onyango needed help because, yes, he's a radiotherapist, but he cannot do everything. And there was no gynecologist who was willing to go and work with him so that you put your minds together. During residency, however, we were supposed to do a few weeks rotating in there. And then that was just the experience, and that's it. So I volunteered to work with Dr. Nyango so that if there was any cancer in women, we would do the clinic together. So we started doing a joint clinic between the radiotherapists and gynecologists. And came in the issue now of we are now moving from just radiotherapy, teletherapy to brachytherapy, where you put the cesium inside the cervix. And that one radiotherapists can't do. So the first training that I had was on brachytherapy. And under the International Atomic Energy Agency, I went to Kasra Leini University in Cairo for 6 months to specialize in brachytherapy. And we are now moving from brachytherapy, where you have a big machine, to actual using cesium and putting them and removing them. It was manual, not the machine thing that they have nowadays. So I went and trained on that. IEA gave us cesium release, and I came here. And I did think for nearly 5 years I was doing that thing on my own with them. So brachytherapy, then after that you do the teletherapy. So out of that came the question that, look, this whole area of cancer requires specialization. You cannot just be that and that. And I requested that I'm ready to go and train as an oncologist. The best oncology training at that time was at the Karolinska Institute in Sweden. So I went to Afia House to ask for scholarship to support. There wasn't any. But there was GTZ, technical person, whom I was supporting in terms of their programs with the Ministry of Health. And I'd done so much work with them. I even wrote some books and manuals with them. That when they heard that I wanted to go for this, they offered that, look, we know you're coming back. This is part of our support here. We'll give you a scholarship. Go to Sweden. So I went to Sweden to do full specialization in gynae oncology. At the end of the first year, things had changed in Afia House. And they decided that they didn't need oncologists. So my scholarship was stopped.
How did they not need oncologists?
Yeah, that was a decision made. I got a letter.
Okay.
Yes, that you'll not. They wrote to GTZ to stop it, and GTZ wrote to me that we are only going to give you, because of a sudden, we are going to extend it by 3 months. But your government has said that we shouldn't give you. So I showed that to my bosses in Sweden. I was already very popular because I knew my work. They were not as good in surgery the way I was. So my boss actually, by the end of 1 year, used to leave me to do all the deep surgery with everybody else, because said, my goodness. So when I told them that my scholarship is stopping, I was there already with my family.
Wow.
They told me, they're stopping, yes. And why don't we employ you? No problem. So they actually gave me a full job. So the next 4 years, not only did I finish the fellowship in oncology, but I also did my PhD. And was examined there and not. And then they offered me a job that now your country doesn't want you. Stay here with us. Yeah.
But I'm perplexed by the decision that the country doesn't need oncologists.
Yes.
And cancer was showing up late.
Yes.
It still does.
Yes.
Like, what kind of policy or who makes this kind of decisions?
It's a question I'm still asking myself, but I think it's a question that everybody in Africa asks. Who makes these decisions?
Yeah.
These stupid decisions.
Yeah.
Who do they consult? Is it just a power game that somebody comes there and hits that? I can understand where it came from, because I believe that, I've been an activist all along. And even as a postgraduate student, you haven't even touched on that when you were there, because you don't know the number of strikes that you went through. So probably somebody thought that this guy is a troublesome guy. So punish him. Yeah.
But such decisions then would fuel the brain drain, because
It does.
hadn't you wanted to come back, you
It
wouldn't have come
does,
back.
because you can't believe it. When I decided to come back, my professor escorted me to the airport crying, crying. Stay here, I want you to take my position. They talked to my wife and said, here, school, everything. Yeah, stay here. And I said, no. I'd said that I would come and train and go and make a difference. So I came back, rejoined the university again, and the rest of it is history. Remember, I was coming back. The gynae oncologist who was there was Professor Juang.
Yes.
But Professor Juang did not have the depth of training that I
you
did.
had.
He went there for attachment and came back. So I was really the first gynae oncologist in East Africa. So I come back and to this country that had denied me the opportunity, and life continues.
Did you have a job coming back, or you?
Yeah, I was in university.
Okay.
Yes.
Okay.
Yeah.
Okay.
So
you
when
came
I
back
went,
to-
I was a university lecturer. Yes.
So coming back, you.
So coming back, yes, I just rejoined the university. Yes.
Okay.
Yeah.
But we have made progress though in gynecology, because now Kenyatta and Nairobi are offering the fellowships.
Yes. Yes, we've made progress in the whole area of oncology, that we now have local training and all that. Yeah, and it's a move in the right direction. That is why people like us went out. Because the history of medicine in Kenya is that people train outside, they come back, they train others. The history of medicine in Kenya is that people train outside, they come back, they train others. That is how the MMed program was created. And people now look at it and don't know even why we have all these strikes in Kenyatta. I will tell you that. Yes.
Why do we have all of those strikes?
Okay. See, the initial training of doctors, it was Makerere. Then Makerere splits and you have here. But still, the postgraduate training was UK. So we had people who were going in to do their royal membership or whatever. And the government would giving them scholarship to go there. But because more and more people wanted, there weren't enough scholarships. So the first thing that there was a talk with the Royal College on whether people can train here, and the Royal College said no, it can only be there. But they gave an allowance that you could actually do your part 1 here
Yeah.
if you were working under a fellow of the Royal College. So part 1 in obs-gynae, part 1 in surgery you could do here, but then you go there for part 2. But even that one proved to be inadequate. So the question was, if the Royal College doesn't want to create the training here, what do we do? And we had now enough people who could train others, people like Professor Marty and so on. But the thing is, at the end of it, what diploma do you give them? Because they can't be a fellow of the Royal College, but we have no colleges here. And here you train under university, The Royal College doesn't train under universities, trains under the college, the collegiate system. So that's where, with the wisdom of that time, they said, okay, university, what can university give you after you've done your bachelor's? It can only give you a master's. So that's when they created Masters of Medicine for us and East Africa. Because we didn't have colleges, but it was an equivalent of that.
The college.
Okay.
Yeah.
Now, at the beginning, that one worked well because the employer was one ministry of health. So after internship, you would go to the district, do a minimum of 2 years, then apply to come and do your M.Med. You would go through the interviews of both ministry and university, and they would pick the people. So what happened was that the ministry would simply post you to Kenyatta. So you are in, like I was in Kwale, but they post you to Kenyatta, the same employer, and you come in. When you finish, they post you back to whichever place that's there. So that worked at that time. And it was very, very well controlled. We knew that this is, you know, where your salaries was coming from. But then as the numbers of undergraduates increased and the demand for postgraduate training increased, the question was, how many can Kenyatta take? Because the residency program should be controlled in terms of the ratio of consultants to students to patients. 2, some students now wanted to come and sponsor themselves.
Yeah.
The university on its part had no reason to refuse to take anybody. For so long as you qualified, they would take you. And they'd bring you to the only teaching hospital which they have, which is Kenyatta. Or later on, Moi. Comes now a problem that because of the numbers, they cannot just continue increasing the numbers to the same hospital called Kenyatta. They go out of ratio. Then later on, when devolution sets in, then you now start having 2 sets of employers. The employer is a county. The county then pays your salary for you to come to Kenyatta, which means that that position is occupied at the county level. So when they come here, they are working for who? For Kenyatta.
Kenyatta. But getting paid by the county.
Getting paid by the county. Now Kenyatta now also becomes a parastatal. So as a parastatal, Kenyatta also has budget for salaries. So Kenyatta, instead of seeing these people as their staff, they also want to employ medical officers. So now you have 2 sets of medical officers. Some sent by the county. The others, Kenyatta is still continuing as if these people don't exist. So you now have 2 sets of people being employed to do the same thing by the same government, but different ministries or employers. The university, in the meantime, remains neutral. They say ours is just teaching you. For so long as you're here, you qualified and you pay your fees,
we'll teach you.
We'll teach you. The fees is supposed to be paid by the Ministry of Health, Afya House, not the county. This Ministry of Health, Afya House, does not even remember when it last paid fees. Until the time of graduation, when the university reminds them, you know, these guys have been here for 4 or 5 years, not paid the fees. So you can see that in all these people are not talking to each other. University doesn't talk to ministry, ministry doesn't talk to the county, Kenyatta doesn't talk to them. Now what happens now is that not only have you crowded Kenyatta and Moi, but you also denied the county's
An employee.
employee. 2, these guys who are here, nobody has worked out what the duration of their stay here should be. There are people who come and finish in 4 years. There are people who've been here for 12 years.
Yeah.
They're still paid by the county, and they're here now. And university is not in a hurry to dismiss them. Kenyatta says we don't even know they exist. So these guys here start complaining that, you know, since I started working, I've not been promoted. So who's supposed to promote you? The university can't promote you because you're not an employee of the university.
You're a student.
Kenyatta can't promote you.
You're not the employee.
Yeah. So you're supposed to be promoted by this guy who has been paying your salaries for 10 years and you've never worked there. And the county can't promote you either. Not just because they have not seen your work, but they also don't have money to keep promoting you, and your position is held over there. So you know what's happening, because I've been analyzing this recently.
Yeah.
Right now, there is 1,000 medical officers in Kenyatta.
1,000.
Yes.
Wow.
Okay? Who come from the counties are sequestered in Kenyatta. The counties are paying for 1,000 doctors to be in Kenyatta for an unknown period of time. So you go to Mandera and you find that Mandera has 35 doctors in training here. And in the county, there's less than 10.
They have more outside than the people they're supposed to serve.
Yes. So you look at their wage bill and you see that their wage bill is big for here, and they don't have space. Yeah.
But from explanation, the solution seems rather straightforward.
Until you know you are in Africa. There's nothing straightforward in Africa. Yeah. You see what's happening? This is now where the history of MED comes in. That MED was started as an interim arrangement until we have a big enough number to form a college. Then we'd move on to the collegiate system that would allow these people to be trained in any other facility rather than the university teaching hospital, which is exactly what's happening in the UK and in the US and in Australia and everywhere.
Yeah.
So, yes, we have actually created the East African College of Surgeons, of OBGYN, and so on. And in creating it, it was now supposed to take over so that you weed out MED and people now come under collegiate system. So under the collegiate system then, Kakamega Referral Hospital can be a training place for OBGYN and for surgery. Because the college will give them the checklist.
Yeah.
Do you have these consultants? Do you have these facilities? Is your patient load A, B, C, D? Is that? And they'll tell them that you can actually take 5 every year. So Kakamega then takes 5 of its own people whose salaries they're paying.
And they continue working
And they
there.
continue working there. And if you know this, Mercy, the most productive time of a doctor is during residency. During internship, you're learning. Once you're a consultant, you're all over the place.
Yeah.
But during residency, those 4 or 5 years, that is when you produce. And that is when you make the person. You become the professional that you're supposed to be. So you miss that opportunity through what's happening here, then we've lost these people forever.
Yeah.
So we have a solution already. The collegiate system is there. Get rid of the MED system. The collegiate system then now starts challenging counties for them to create the kind of facility that can allow training of people to that level. So you start improving the
quality
standard
of care.
and quality of care there. And that's it. It's a win-win for everybody. Now, recently when I was doing the analysis, you know what I found? Kenyatta National Hospital came to my task force, and one of the requests was that they needed money to employ more. They are understaffed. So we tell them, are you understaffed in doctors? Yes. So they tell them, okay, give us your staff establishment. And they gave us only the one that they're
They've
employing,
employed
not the 1,000 who are
that
there.
are working.
Yeah. So we asked them, what of these 1,000? They say, we don't know anything about them. I'm sitting with the CEO, acting CEO albeit, and the chairman of the board. And they say, we don't know about those people. Then they say that we also want to employ consultants. There is 600 consultants in Kenyatta National Hospital.
Well,
Half of them university. So we tell them, but this university, and they're not your consultant. No, those are not ours. Those are university staff.
but they work.
Yes.
They
They said,
serve the
don't they do
patients
what
in
down? Don't they
KNH?
go to the same theater, same clinic?
Yeah.
They say we are not sure. I was being told that, Mercy, 2
But-
months ago. I said, I've been there. We are the ones who are working. How can you say no? No, Mwalimu, your time, things have changed. We are now Kenyatta National Hospital, a parastatal of our own. So here you are, and I did the counting. That the number of gynecologists that they have in Kenyatta, and the number of theaters, ORs, and the number of clinics, for you to do 1 week of surgery in Kenyatta, it will be only once a year. Because the others are there.
They have-
50-something gynecologists with 2 theaters. Or 4 theaters.
Yeah.
What's that? So it's become ridiculous that we can, same government, bring in employees. Some are paid by university, some are paid by the counties,
county.
and some are paid by
Kenyatta.
Kenyatta. And they all say,
We don't
we
know.
don't know what the other one is doing.
What's happening at that point with all of these people? Because it looks and sounds ridiculous.
Everybody is doing their own practice. If you want to survive and do well in Kenya, get posted to Kenyatta.
Yeah.
Lack of accountability, run your clinic there and that's it. Do you know that that's when I found that the spinal injury hospital has 2 gynecologists?
At Spinal.
Yes.
What are they doing there?
I asked, is it the spinal people who are very fertile now that they are there, or is it the staff? It's a 30-bed hospital.
Yeah. it's a
So
small
how do
facility.
you send an obstetrician there? Not a spinal injury specialist. And when you look at it, you see that these are, you know, those ones around Afya House. Those are favors being done to children or people who don't want to go out there. And you say, yeah, here. There's nothing they do at spinal.
Yeah.
Yeah, you'll go to Mathare. I've looked at the list of the people posted to Mathare. It's the same thing. So Afya House is doing its own posting. Kenyatta has its own. Counties have their own. And then they come into this melting pot called Kenyatta National Hospital. And it is a shame. Ridiculous. Totally ridiculous. So for somebody to sit there at my age to tell me that the lecturers in University of Nairobi don't belong to them at Kenyatta, so they must employ an equal number of consultants.
That's creating a very, very inefficient system.
I don't know. I think you're being modest.
I'm not as blunt and as forthright as you
Yes.
are. Yeah.
Yeah, because how can a country that claims that we don't have money to employ these people do that?
Yeah.
You saw what happened in Kenyatta University Hospital. They cut the university out of the hospital and they started employing consultants. So the university lecturers were now giving service at Kiambu Hospital. But some of their more specialized surgeons, they can't do anything in Kiambu. Kenyatta University is advertising for those kind of people.
And yet they're just next door.
And those guys are across the fence. And you can't sit down and say, hey, this is your hospital. Come in here. So those guys, for them to practice their dexterity, they go to private hospitals to do it. That is, if you want to know the madness in this sector, in Kenya and in Africa, that's it. You don't have to be a neurologist to see that there is total stupidity. Yeah.
So what's your recommendation to the government?
The first thing is, what is my recommendation as a professional to my professional colleagues? We've got to get back and take over the discussions here and be professional about it. Because it doesn't make sense what I've told you,
No,
that you have 1,000 young doctors here for undefined period of time being paid by Pokot. Where's Pokot? For these guys to be here. And where they are, they say we don't even know that these guys are here. So it makes sense. Immediately, let's go to the collegiate system.
Decentralize it.
Yeah. And then MED, let these ones be the last groups. So teaching of postgraduates will now be decentralized. Those facilities will benefit from more equipment and everything because the college system is tech.
Yeah.
How many gynecologists do you want? There must be a gynecologist there. There must be a fertility guy there. That's it. County, are you ready? Yes. We can now allow you to train your own people under the collegiate system. Isn't that an incentive for them to be able to move forward? Move forward.
It is.
Then Kenyatta also starts taking the number that it can teach. Right now, they're overloaded. They have more trainees than the institution
Can handle.
and the Nini can handle. So we are actually diluting training into Kenyatta. So move this thing over for quality. Get the collegiate system on board, phase out the MED system, and decentralize. Now, do I need to be a president to do that? No. This is a professional thing. Let everybody sitting in Afia House at the county level, let's have a meeting this afternoon and we implement it as from tomorrow. It is not a budgetary issue.
And you'd actually said 75% of our problems don't need any budget.
Absolutely.
And don't need any new laws.
No. And that is what my task force, when it was still allowed to work, was showing. That yes, 75% of our problems are non-monetary. They're not even legal. It is purely administrative. And we move forward. 6 years into my task force, there's nobody who has given us a number of health workers in this country. And the number who are in training. And the number who are going to graduate next year. None.
How?
Because they don't know.
Safaricom can tell us how many people have M-Pesa, have mobile phones.
Absolutely.
How can we not know?
Absolutely. Because knowing means that you are entering the cartels that in this sector. Those cartels sit in these institutions. They sit in Afia House. Quote me. And this is a kind of thing that we have fostered. How can you be paying people salaries every year and you claim we don't have enough money, but you don't know the numbers? How can you say that you don't have enough money for interns, but you don't know the numbers you are expecting? What are you budgeting on? And then there's something else. Let me tell you this. Internship has also now become another cartel. Traditionally in health, internship was only for doctors. Kenya has turned that one round. First of all, we have only 43 cadres recognized by the government. But the number of health courses
So many.
is over 100. And if you look at some of those degrees they're giving you, you wonder, what is this person going to do? But the parents take them to those colleges believing that mtoto yangu anasoma atakuwa nurse, atakuwa daktari. Some of them as ridiculous as BSc in...
Clinical medicine.
No, paramedics.
There's no BSc in paramedicine.
Yeah, I've looked at it. I've sat with the deans of the 40 schools that train people in health sciences at university level, and I've asked them what's going on. And they've said, sir, we are in a mess. Each one of those trainings, you go and get a member of parliament, draft for him a private member's bill. It is passed. The Ministry of Health, if they're given that bill or to review, they never review it. So it is passed that there will be these people who will be trained here, and at the end of 4 years, they'll get their BSc and 1 year of paid internship by the government. It is written in the bill. So everybody now comes in for 1 year of employment with the government in the name of internship. Yeah. In training in health, there is training that requires internship, there is training that requires some supervision. So what is happening is that the colleges then now get away with practicals. They don't do practicals. They just do theory because you're going to go for internship for 1 year. So at the end of the graduation, people reach Afya House. Nimetoka hii university hii. And some of these unrecognized cadres even have unions already. Unionism is another cartel now. So the union is there with these guys that here, and the act is this. So why are you denying us internship and salary?
It's by law.
It's by law. That is why you see that mess in the grounds of Afya House. We've created it because we've not taken care of the training system. How many, what it produces, and where you take them. So we think that you get a minister and go and put him in Afya House. He's never been in this sector. And he comes with this magic wand. That now I'm Duale or Nakumisha, and I'm going to solve this thing. Does he know the history that I've given you? Does he know how med is messing up everybody? Yeah. Leadership is everything. And it is informed leadership. It is honest leadership. Because the biggest challenge for this sector in Africa right now is that combination of knowledge, integrity, and doing it for the public good. Those three things. If we can get that back to this sector, then we'll be delivering more, way, way more than we are. So if you give me one side is that kind of leader, and on this side is a bucket of cash, and you tell me, Khama Rogo, which one do you choose for the sector? I'll take this one any day, because this one here is going down the drain without this. But this one here will make the use of this be accountable. We've lost it.
But we also in a society, a low trust society, if I may call it that, where it's hard to distinguish between that, the last component you've talked about, leaders that are doing things for public good. So it's really difficult to distinguish when somebody is doing something genuinely for change or that they have their own hidden motives around it. So how do we, as a society, support somebody with good intent?
I think that we have two issues to handle here. One is a professionalism side. That who is a good professional? That one is up to the professional and their colleagues, because as a professional, you belong to this group. The second one is public and ethical. If you look at the countries that have made strides in this sector, you'll see that it is marrying the two. There are, first of all, what is your record before you're giving that post? Because you don't just jump from a medical student to the top. So there's some 20, 30, 40 years of performance that should be put to scrutiny. Do we?
No.
No. You just hear that somebody now is CEC in Busia. What is the criteria for a CEC in Busia?
Probably supporting the governor during campaigns.
Precisely. Now, medicine is like the army. A good army is one that has ranks that are based on a criteria of performance
And merit.
and merit. The moment you mess that one up in the army, you've lost your army. That's exactly what we've done in health in Africa. We've lost that ranking and that respect that comes with the position that you hold and the delivery on that particular position. So that again is a deliberate thing. It is not anything that has not been done elsewhere in the world. That's one. Number two, there must be a performance assessment every year. What did you set out to do in January? What have you achieved by December? This sector doesn't do that. The budget, have you ever seen a county with its annual budget, or even the Ministry of Health saying that this is what we're going to deliver this year? This is where we are. No, never. And why is it that? Because it would show that there's no delivery. That's number one. Number two, that even the budget that's appended to those activities never comes. You cannot run the health sector if you're going to release the budget in May for the financial year that's ending in June. And then you expect that during the last 11 months, things were just okay. And now you're paying your bills in May. It doesn't work out that way. It's not like in education, where you can say that teacher so-and-so is coming and is teaching you, and will pay the teacher at that. Here, you are talking about surgery that was supposed to be done on that day. You're talking about a delivery that was supposed to be done in January. You're talking about this cancer where the patient has only 1 month. Otherwise, that thing moves from operable to non-operable. So we got to look at this thing differently. It cannot be just a political game that we play everywhere else.
Then it calls on the professionals to
Absolutely
change the course of...
And that's why I told you that it starts with us, that our house is not in order. We have now gotten into this thing where people claim to be what they are not. People rise because you are closer to power than that you are the person who has a vision to lead us. Where is vision in this? Where is vision when the leadership in Kenyatta says they don't know what 500 university consultants, these are the most highly trained people in this country. They say we don't know what they do. 1,000 medical officer, how many doctors are employed by the government right now?
Was it? I don't remember the number.
I think
but
it's
less
than 300, 3,000.
3,000, yeah. 3,000. If you count the interns, maybe 4,000.
Yeah.
Yeah.
Now, 3,000, 1/3 of them are in one hospital. And you're talking about 47 counties that are supposed to be.
55 million Kenyans
Yes.
plus.
So how can you continuously keep, I haven't added Moi. Yeah. So if you add Moi, then you're really talking of nearly 50% of actively practicing young doctors are sequestered in two hospitals that deny that they know them.
Do other people see it with the same urgency and seriousness that I'm now seeing this?
No, because first of all, they're not serious. I mean, we take health sector to be just something that you say, oh, this year we've employed 20 nurses. No, it is not the output side. It's not the inputs you're looking at. It's the outcomes that are there. If you employ 1,000 nurses, what does that mean in terms of the quality of care that is happening down there? If you take the community health workers and you say we now have this with this budget, what does that mean in terms of the impact on the people that they are meeting with? It's not there. It's a game. And unfortunately, it is a life and death game.
Yeah. You said we are overtraining, underemploying, and exporting human resource, and you gave the example of this area.
Yeah.
So what can we do about that, or what should Kenya do about that?
You see, Kenya has tried sometimes to be what it is not. And this is now wearing my global hat. And I'll tell you, let's take it from the point of view of Medical Training College, MTC.
Yeah.
The MTC Kenya is a Nobel Prize undertaking. Kenya should get Nobel Prize for the MTC. Because globally, it is the single most effective, low-cost production of middle-level health workers anywhere in the world, in the history of medicine. Did you people know that? It is something that the outsiders, when they come here, they used to come here and say, my goodness, I wish we had the MTC. That is why you don't have shortages of radiologists, of orthopedic technicians, of all these things. It is because of that creation. And it is only in Kenya. Others have tried to create it, but it is all fragmented. So the medical training and the quality of people from our original MTC was top class. But you know, we decided to politicize MTC. So from the original 20 colleges, or one college and then to 20, we now have, I think, 87. So every politician, every MP wants an MTC in his area. Have you been to some of them?
Yes.
I have been. They are worse than my local primary school here. And that's a place where you're going to train somebody who's going to decide whether you're alive by sunset today. Simply because we want to have those colors of blue, green, and water at the gate of a place called MTC.
The maroon.
Yes. That's it. So, is that wisdom?
It isn't.
Have you ever seen anywhere there has been serious discussion on just that? Never. Members of parliament are busy voting so that I have an MTC in my constituency. MTCs is no longer even a county issue. It's constituency issue. And some constituencies have two.
Yeah.
But you go there and see what they are calling a training institution for health. They're worse than TVETs. They're worse than TVET.
I've seen
so
some.
What you're asking me, where does that debate take place? Does it take place in the professional journals and meetings? No. And then even if it took place there, where do you take it to the decision makers? Is there a forum for us to sit with members of parliament and tell them, stop this subdivision of MTCs into unmanageable units? That one. So if you look at the number of courses that are done at MTC, and you say that all of these are being diluted, what are you doing to the health sector?
You're producing poor quality workforce.
Now.
And the outcomes will be worse than they are.
Two, the regulator of training, Medical Council, Nursing Council, and so on. They're the ones who are supposed to license an institution to be able to train that. That has been taken away from them and left to Commission of Higher Education. So these guys come and say, you can only train 50 doctors. But when you go there, you find that there's 500 because they are getting many fees. Two. And what I'm giving you is facts that I have and that have been placed in front of the task force. Two, indexing. The only professional group that still adheres to some indexing of students is nursing. Indexing is important because you cannot qualify after 6 years if you didn't do the first year. You see what I mean?
Yeah.
So anybody who's going into a medical training ought to be indexed and given that number for life.
From day one.
From day one. So if 6 years later you're now graduating, then should be this same person. Do you know that right now, in the graduation class for MBCHB or whatever it is, there are people who only appear in the graduation list.
Where have they been?
They've never been in part of that. They came to graduate.
And they'll come and treat us?
Yes.
How?
How? Because they've now been given the power to read and write.
That should be criminal.
Yeah, the criminality is what I'm talking about. We are criminal in this country, in this sector.
Because that's somebody you'll entrust with your life.
True.
And they don't even know.
Yes. It is happening. Do investigative journalism, it is there, sitting there. And the resistance to indexing is just that. We don't want the professional regulators in this thing. The University Act gives the Commission of Higher Education the authority to decide you are a medical school, you are a nursing school. It's higher education. So indexing should be inside this. Even our students who go outside in Romania should be indexed. So that by the time they come back, we know that. And these things in a computer, you can see that right now we have 10 students in China. They should be coming back next year, God willing. So our planning then for internship is there. That these are the people that we expect for internship.
If I look at just across the road on Gong Road, Nairobi Hospital is, well, despite its problems, okay, we can go to even Aga Khan. It runs by itself without, you know.
Yes.
So Kenyatta, Moi, and
because
this hospital should be able to be
Kenyatta pays labor. Nairobi uses labor. So they're paid on that side and they come to work here. There's not a single thing that Nairobi Hospital can do that Kenyatta can't do.
Yeah.
Because the skills are there and the equipment is there. For 10 years, I led the global program in the World Bank, making sure that this thing works. Because medicine cannot be divided into this is private, this is public. Patients can't be a public patient and a private patient. They are for care. So you give them to best care possible and most affordable. And you do that. The biggest driver of cost in health in Africa is not the private sector. It is the dysfunctionality of the public sector.
How?
If Kenyatta can do renal transplant in the way it should do, nobody would go to Nairobi. And if Nairobi receives few demand patients, they reduce their cost. Because the cost driver is on the other side of Ngong Hills. Did you know that when government instituted the medical equipment scheme, with all its problems, the cost of MRI and all these imagings went down in the private sector? Why? Because there was
enough supply.
Yes, and competition. And it was the same person who's reading this thing on this side who's doing it
Reading
on
on
the
the
other
other
side.
side.
So the moment the public sector starts working for public good, then the private sector becomes a supplement. And as a supplement, you cannot control the cost. But the moment the private sector now is a provider, then the public sector is a supplement. Because right now you only go to the public sector because you can't afford it. You don't go there because you like it. And that's a statement that people are making with their own legs. That I'm in Gong Road and I have to decide, do I stand left or turn right? Can we live through the mindset of that patient? This one I go, I know I'm going to be poor, but at least by the end of the day, I'll know what I'm suffering from. This one I go, I know they will not charge me anything, but at the end of the day, I'll not have seen anybody.
And you'll have lost your dignity.
Yes, those are the choices in health. That if we want to improve healthcare in our continent, we have to walk through the experience of that individual. Unfortunately, the moment you become a professional, you stop being mindful of that journey because you're now sitting there waiting for these people to come. You don't know how long the queue is, but you want to take 3 hours of lunch. You leave these people here, them they woke up at 5 a.m. and they are going back 100 kilometers on a road that must take them home. They cannot afford a night there. But you're having your lunch because it is lunch break. It is there in my calendar. It is lunch break. This is not what we were taught. We were taught that the last patient, if you haven't seen him, you don't leave the seat. So your lunch break is dependent on this seat being empty, not the
The calendar.
timetable. No. So these are the simple things that eventually you find that they are mixed with politics, and people don't say they don't know what to do. No, we know what to do. We know what to do.
You've talked about, and we venture into insurance here. You've talked about that if, as a Kenyan or an African, if I have an insurance card, in this case, let's talk about SHA, the Social Health Authority, and so what they're offering, then I become a market.
Yeah.
Could you?
You stop being a problem. You know, I've been, for public disclosure, I've been involved in the discussion of every social health insurance scheme in the continent. I know them deeply, whether it's Ghana or in. I was greatly involved in the debates of NHIF. In fact, as chairman of Kenya Medical Association, I sat on the board of NHIF. The first chairman of KMA to sit on the
in the
board
board
was
of
me.
NHIF.
And it was fought for. They never wanted KMA there. The issues here are very, very simple. That the way we have structured the health services in Africa was that it was a favor to a few people who could get there. The colonial system, we are very, very good at working in systems that somebody has created, but we are never good at creating our own so that people come to cooperate. NHIF, fortunately, was one of those pioneer programs that Africa can look up to and say that, yes, something like that. But even NHIF was never started with the intention of covering everybody. It was the intention of covering senior civil servants who were coming into government in early 60s. Their British counterparts, whom they were replacing, were covered by the British NHIS. So they could go to Nairobi, they could go to Aga Khan, they could go to war memorial in Nakuru.
In Nakuru.
They could go to Kitale, they could go there. That was paid for. But the guy who's taking over from you could not go there. So this is the beginning then of saying, can we create something so
us.
that even as we are co-workers, they can also come there. So it was initially for just that top cream of civil servants. Then now it moves on to all civil servants. Then it moves on to all people in formal employment. And those steps are, each of them are as important because they're consequential. The last step was going to be what to do with the informal sector. And the informal sector is made up of two subsectors. One is informal able, and they are the richest people in Africa. The richest people in Africa are not people who are in formal employment. Because your salary...
You depend on your salary.
But informal sector. Let's not just see it in the Juakali guy who's on the street.
Or a mamamboga,
Yes.
boda boda.
Yeah, look at that whole chain. They are able. Then there's informal sector and able. This is where the indigents come in. So informal sector able should be able to pay.
Yeah.
Informal sector and able, the indigents, will never be able to pay.
Somebody has to pay for them.
Yes. And that is the responsibility of government. So in that journey, it was this group here. Two things. One was, how do we make informal able pay their rightful amount? Because formal, it was based on your salary. Informal, we didn't know. But because we hadn't sorted it out, we decided that we'd make them pay the lowest of NHIF. So it was 500. So even if I were a billionaire in private, informal sector, that
500.
was. So it was a question then of doing the maths and economics and coming up with a way of graduating them so that they pay their bit. Informal sector and able indigents, that is a government responsibility. Anywhere else in the world, let them do it. So this has been the debate that has been there now. If you work in the fields in which I've worked in, there are some cynics in the donor world who always said, probably with some iota of truth, that this thing can't work in Africa, social health insurance. One, it's because these guys are not digital. And you can't run an insurance scheme on manual records.
No.
Number two, you can't trust an African with any pocket of money. None. So if you're going to collect this money and put it there, whether it's a rambe for burial, somebody will put his dirty fingers on it. So don't bother. Now, the digital myth, Kenya helped kill it through M-Pesa. Because all of a sudden they're waking up and say, what? So if some of the most secretive things, secrets of a man or a woman, are their money and their health. So if you can, these people can trust this phone to carry their money, could they also trust it to carry their health information? And the answer is yes. Just do it with the same diligence that Safaricom has done that. The moment that diligence goes, trust goes through the window. You know, we can kill Safaricom in one go, just like that. Yeah.
Trust.
Just one rumor, and trust goes, and Safaricom is dead. So that is the lesson that we should have taken. That this thing here, it is not just a political pronouncement, no. Because there's no politician who came and told people, please put your money on the phone. And if they did, nobody would have put the money there. So what makes you think that they'll put their money into this thing when it is their health? It isn't. So the messaging and the messenger,
Is equally important.
yes. And we've lost it on that because we want it to be a political thing. So now comes the issue of the history of where we've gone. Remember that Kibaki was supposed to sign the universal thing in law when he came in, when Ngilu was minister.
When Ngilu was the minister.
Nikal was the peer, it was the DMS. And it was passed in parliament.
Yep.
It went to the president didn't sign it. Why? Because the country director of World Bank went there with businessmen who ran insurance. They say, Mr. President, this thing here. And that was the time that we were getting this money to expand education. And the president had to listen. I was sitting in DC. So I know each and everything that happened there. Not that it was bad, it's simply that the interests were different. Okay? So subsequent to that, interestingly, major reforms took place in NHIF. And if I tell you, there is no African country that has received more delegations to learn about social health insurance than Kenya. Receiving. Yeah.
Not the ones
No,
they go to
no.
benchmark outside.
No. People coming here to look at both the history and how it works. My own program brought in nearly 30 delegations from across Africa, Francophone Africa, Lusophone to that. And the most remarkable thing about it was the IT system. NHIF IT system was regarded as one of the most innovative in terms of claim system and all. And when we brought people here from Nigeria and so on, all these guys in the Agbadas, they didn't believe that you say this is Africa. It is happening here. Kenyans didn't know that they had this. So we brought them here to come and learn. I brought Ghanaians there because theirs was failing. They had started on this big thing. Was failing. Came here to show that. I went and helped them redo that. And the means testing.
Yeah.
Created for Ghana a tablet for means testing.
We take a walk as Professor Khama narrates his experience in Ghana, working with them as they navigated how to develop their social health insurance.
Before you came in, you were telling us a story of when you're in the border of Ghana and Burkina Faso.
You know, we are testing the gadget for means testing.
Yeah.
And there has been two means testing methodologies in Africa. The one that we did for Ghana, which you can actually adopt here very, very easily. And Ghana was doing it at a time when connectivity wasn't as good as Kenyans. Here you are everywhere.
Everywhere.
Go. And that's why we're going on top of trees to see. Will be there. And then we use that to market to the cell phone operators for Ghana to put masts out there, because we say big business, big data is coming. And big data pays more than these calls.
Yeah.
So the incentive then was now for them to do that, rather than the government coming to say, how do we invest in this? That shouldn't be government investment. And that's where public-private sector comes in. We've not used enough of that for the benefit of Kenyans. But the other one was the Rwandese one. The Rwandese one was mixed with tradition. You see, like here in the village, if we say that 1/3 of our population is indigent, so it is 3 out of 10. So you take a ward, and that ward then is divided into villages or communes. And you tell them that out of each 10 households, give us the 3 that you think are most in need. What we found was that the thing is more accurate than means testing.
Then my last question is on the South Sudan. Okay, the second last. The South Sudan healthcare. What lessons did you pick from there? What worked?
If you have a wish, that God gives you a wish to go to the moon, and you start a new health system there. Nobody has ever tried anything. You go to the moon. Yeah, that's a kind of sense that I had of South Sudan. I went. South Sudan was part of my portfolio. In 2006, that's when you are going to medical school.
Yes.
Yeah. And me, I was being asked, the peace agreement had been signed in Naivasha, General Powell and the others. And South Sudan would go through this transition. So the Northerners would leave. Up to that time, the Northerners controlled only 3 urban areas: Juba, Wau, and Malakal. So they were like garrisons with their army there. The rest of South Sudan was under the rebels, not organized. So there was no health care. So if a lady was in labor, it would be the TBAs with her there. If she walked out and told the men waiting here that there's nothing more I can do, they would pick their jembes and start digging the grave. Because they would just, she'll be dying. So I get this assignment that South Sudan is coming, World Bank wants to support this, and we don't know what to do. So I go to South Sudan on my first trip, fly from Washington. And I meet the minister and doctor colleague who had graduated in University of Khartoum, South Sudanese, but the last 30 years he's been a refugee in Australia. And he's sitting under a tree. So we introduced Dr. So-and-so. She tells me, "Thank you, my brother. You have come. What do I do? I'm the Minister for Health. There's no office, there's nothing, there's no record, nothing."
Isn't
South
that-
Sudan, they've already decided that they're going to divide it into 10 governorate states, each one with a governor. So where do you start? It's one thing saying you're going to Afia House. There was no Afia House. So I worked with this guy over the next 2 years. Moved him from the tree shade to a tent. From a tent to a container. From a container to a prefab. And from a prefab into the ministry offices. They had no idea what facilities exist, because all facilities that were there were being run by humanitarian NGOs who are getting big money, that we have 50 facilities. Later on, I did a count. Dr. Rai actually walked through those, because we were trying to identify them. These guys were taking money for things that didn't exist.
They're not there.
They were not there. And they say we have all these health workers that we are paying, so we give big money. And they all weekend they were in Nairobi. So to get that moving, start from zero. Who are your human resource? Nobody knew if there was any doctor anywhere. There was one anesthesiologist. That's the only thing I can remember for the whole country.
So in essence, there are just 3 of you. The anesthesiologist, the refugee from Australia, and yourself.
Yes, but you have all these international humanitarian NGOs that say we are working here. I'm a ref was there in one of that they were training health workers. Big budgets, unbelievable budgets. So trying to organize that, to cut a long story short, I organized the first South Sudan Health Summit. So you're now bringing every state governor and their minister for health in Juba. We put a tent for them. There was no place where. Then to bring them in, because you see, there was no bank in South Sudan.
Cash business.
There was no telephone. There was no newspaper. There was no radio. So when people talk of tenders, when we started doing tenders, tenders were being placed in newspapers here and in Uganda for South Sudan.
Right.
And the tenders would be brought to a tender box where we got a welder to make a big box, steel, with an opening there. So that's where they come and put in their tender. And then the day of opening the tender, the guy comes with everybody there and akata hiyo chuma. So they say these are the tenders. Because we had to go to the World Bank transparency. So when these people came, we leased planes from Wilson to go and get them from their states because there's no roads. Under that government, they used to come to Juba and you're given the salaries of your civil servants in cash. So you carry it with your askaris to this place. Nobody knows who these workers are. It's just a figure you have given in cash. So these people, we went to get them. Some of them, they told us, okay, how can we get you? Oh, there is a mini strip here, a plane can land. You go there and you find there's only cows or there's water. They come back. Anyway, we organized the first one. Some of them minister in one state, Upper Nile, meets a minister in Jonglei state. They were schoolmates 40 years ago. One is had been a refugee in America, one has been in Australia. So there's nobody who knew what Sudan is. You know, even up to now, people don't know the parts of South Sudan that people don't know. They have some plants and some animals that nobody knows. So we organized this thing for the first time. This was like a reunion of sorts to discuss what is it that you people want. Then, human resource, getting that, what is the training needs and what is that, who's going to do it. Then state, you know, it's like now we have the counties here. There was not a single 1 foot of tarmac in the whole, even in Juba. Just potholes, worse than this is my road here. So now it was to get vehicles for the ministry. So I ordered the first 50 Toyota 4-wheel drives. And it was held because the American government had put an embargo on Sudan. But they hadn't recognized South Sudan. So when we ordered those things from Toyota, they read that and say, Sudan, we can't. I had to get the country director in Ethiopia, World Bank, who was Japanese, to talk to the head of Toyota there and explain to him that this was a different Sudan.
Yeah, it's a
So
different
those
country.
vehicles they come to Mombasa, then they have to be taken all the way through Uganda. Medicine, the first consign of medicine that we ordered, come to Mombasa in containers. Then they go there. There's no central medical store. So we had created a cold tent where they would go. So if they're coming in December, Christmas Eve, the company that was transporting those things called me, I'm in Washington, that they've been stopped on the Ugandan border with South Sudan, that the soldiers there don't know about this consignment. What do we do? And we have medicine that it's hot, 40 degrees plus, medicine that would expire if they are not there. So you're in DC. So I called the minister. The minister has gone for Christmas with his family in Australia. Because all of them, their families were left out there. They were coming in here like expatriates. So I tell them, okay, now what do we do? How do I solve that? The Minister for Defense in Uganda, Cyprian Nani, was my student here in gynecology. He never finished. He was doing postgraduate. So I call him, it's Minister for Defense. And he tells me, sir, he still kept calling me, sir, don't worry about that, we'll sort it. So he's the one who sent Ugandan army there to escort those things to Juba. We had to start filing. You know, these things you say, which file number?
Yeah.
There was none. I got somebody from Kenya here to go and start training people on filing. Creating the need for human resource for everything. Computers. The first computers, desktop and laptops, the one who got in there. Initially, JICA came and JICA asked me, what do you think these people need most? I told them computers. They just laughed. They couldn't imagine that people would.
As basic as that.
I said, that's what we need. Yeah. So the South Sudan was a labor of love and passion to create a health system out of nothing. And we created this thing, the hospital started working and everything. And then just after I moved to another portfolio, they start war again. And they broke everything down. They broke everything down.
After all that work.
After all that work. Now, whatever we have in our countries, colonial side, they were bad and everything. But let us not underestimate what they left behind.
Yeah.
Because starting from zero, I think I'm one of the few people who have started a health system from zero.
Yeah.
Zero, real zero.
Zero.
Yeah. And I'm forever grateful for that. Because I don't think that there are many opportunities in the world where you can do that.
No.
So the opportunities to get things done properly, to procure properly, to have a different approach, to train properly from Juba Medical School and all that were there.
Yeah.
But the big problem came because far too many of their leaders had been in Kenya and Uganda. And they've learned that leaders here are not poor people.
They've learned bad manners, in short.
So they came with those bad manners, where you steal, and have they not been stealing? Yeah. So you've seen the opportunity of starting afresh and doing it right, and how difficult it is to do things right because of selfishness. So until this DNA of selfishness is gotten rid of, I'm afraid that this sector will be one of the casualties.
You said we need a new crop of, something should take the current crop of leaders out.
Yes.
En masse.
Because I had the opportunity to work in Ghana, and I've had the opportunity to see and discuss what Jerry Rawlings did in Ghana. You know, there was Jerry Rawlings 1 and Jerry Rawlings 2. One, they gave back to the government. Second one, he stayed. And the second one, what he did was that he rounded up all these political leaders, rich people, party, many what, and lined them up on Labadi Beach in Accra and shot all of them. Jerry Rawlings became such a controversial person because there are people who hailed him and there are people who hate him because you killed my father. I worked with both children of those who think that they did the right thing and children of who were left orphans.
Yeah.
And I had a chance to chat with them. And do you know what he says? I had no option. Either we have a new Ghana or leave it in the road. These guys control everything. They control the police. They control the judiciary. They control the banks. They control the businesses.
Everything.
So even if you send the police to arrest them, they can't be arrested. If you take them to court, the case never goes anywhere. Postponement. The judges are all them. So you can go there with all your good intentions. And then when you organize elections, they just reorganize themselves. And they are the ones who are heading the parties. And they're the ones who get back. So what do you do? What would you do? He said, to give these countries a fresh start, let us change the players a little bit and see if they can abide to new rules of this game called soccer. And the more I see what's happening in my country and around the region, the more I'm convinced that as inhuman as it is, as undesirable as it is, the sacrifices that we have to make for a new beginning are much, much more painful than we are willing to contemplate. Because if you look at the COVID billionaires, and I've asked myself, because I sat glued to my television when some of those entrepreneurs were being interviewed by the parliamentary, the Senate. First of all, they look pretty well fed and very confident. And somebody goes there and justifies that God loves me. One morning, I'm just passing by the gate of Kemsa, and something tells me, ingia ndani. And then I go there and I find this thing and the papers there. And I feel it.
And I get...
And within a few days, I have this contract of 30 million. My business was that I was selling flowers. So I've never done anything in health sector. And they say God is great. I'm blessed. I'm blessed. Invoking the name of God. And that was happening at a time when the risks of working with AIDS patients and therefore needing protective gear was at its peak. So not only do they not supply, but they give you fake ones. So what is it that drives that kind of greed? Is it greed? Because I know the greed from the animal side, that if I throw a bone there and there's dogs that come, they fight for it. But they don't kill each other. Once one gets the bone, what is this thing that happens? And at the end of it, the MPs shake her hand. And she's happy that she's explained to Kenyans how she got this thing.
But is it because the person interviewing was also part of the whole scam? So it was just for public, playing to the public gallery?
Your guess is as good as mine, but the question is, if the systems of accountability are those so much infested, so where do you go?
There's nowhere. There's nowhere to
So
run.
put yourself then in Jerry Rawlings' position. accepted that that's a way of life, or say that I took these risks and I really want this thing to change. And there's nobody who can doubt that since then Ghana has been a better place.
It is.
It has been a better place. I'm not prescribing anything for them, but I'm saying that in the depth of our contemplation on how to redeem what must be redeemed, because we cannot go on like this. It's bad for everybody.
Yeah. Needs radical surgery.
It needs radical surgery. And radical surgery is not what anybody wants, but it's an essential part of the therapy. So I believe that as part of the healing, there has to be a forum for much deeper discussion of this sector. I predicted those years back that even in Africa, debates on the health sector are going to determine the presidency. I think we have arrived there.
We are there. Yeah. Not almost. We're there.
Yes.
We're there.
We've arrived there.
We're there.
That because this of all the sectors where you can't get away with with lies, it's
a health sector. Yeah.
If you're coughing now and we find you have TB, but we don't tell you the truth, the TB doesn't disappear. It just gets your lungs.
It just eats you and eats you.
And this is a thing that I don't think that our guys know. Because the health sector in the whole of Africa has more contracts, procurement than any other. Remember in the height of HIV/AIDS, one of the countries that I was in my portfolio, we've given money to buy condoms. And they confirm that the condoms have arrived. And you go to the country and you meet the senior people, they say, tuko sawa. Then something tells you to go to the stores and see if they arrived, and you find something tells you, just ask them to open one of them. And there's hesitation. Then you take a knife and just open. What do you think was in the box?
Nothing.
Nothing?
Maybe other things which had been imported other than condoms.
Cotton.
Cotton.
Something else. Something different.
It was Viagra.
Because somebody has seen a business opportunity.
Big market.
Yeah.
Big market, going like hot cakes.
Tragic.
So, you see, when the difference between human beings and other animals is that we have conscience, or we believe we do.
We do. We should have.
Yeah. So that's why a dog will do certain things that a human being wants to do. But this one, I think the dog is better than us.
Yeah.
In the height of HIV/AIDS, somebody has given you money to help your people. So what's the difference between that and the COVID billionaires?
No difference.
It's the same.
It's the same.
So this is an environment in which you are asking me to explain to you how we make the health system work. And then we start by training. So what do we do in training? We say, we have few health workers. So we start opening these schools.
Numbers.
And we create numbers. And we graduate people who didn't train. Then when we have those numbers that we don't even know, you say there are now so many, now let us get them jobs outside. So that now becomes a metric for successful government.
You're training for another market.
Yes. Now, what makes you think that that market respects you?
It won't.
Yeah. Because if you want to train for that market, get their curriculum. Let them open the schools here and you train. That's what Philippines and Egypt does. So it's not run by your money. It is run by
By their
them.
money.
So you come here, German curriculum, we teach them, they know German, this is their schools, they fund it, go. But there's no way in which you're going to take my money. Bring out these crooked guys, whom I can't even employ here, and tell me that the Germans are so desperate that they're going to allow them to run their ICU.
No way. No way.
So, but why do we make it look like we are solving our problem?
It's the pot. Now we've added some pili-pili.
It has taste.
Kafiri-firi kwa umbali.
It's a painful thing for
Yeah.
us who started with a system that we thought we could grow.
Yeah.
It hasn't happened. We wish the next generation better luck than we've had. We take responsibility for some of the things that should have been done differently. For the fact that as professionals we don't have a backbone will allow anything to happen. It's the same mistake that the Americans right now have with Trump.
Yeah.
And you can see what he's taking to them. Yeah. So I don't know. But one thing I know is that when the health sector is in the hands of honest people who are passionate about what they're doing and do it for the people, then it is the easiest sector to run. Because the sector that you can monitor easily. I'm sick, I'm well. I'm on duty, I'm not on duty.
I've done 10 surgeries.
I've done
or
10
none.
surgeries, that's it. I have a queue out there, I saw them after 5 o'clock.
Yeah.
They're all gone home. Done. Yeah. Anything beyond that is not health sector, it is something else. And I'm afraid that what we have in Africa at the moment is a shadow of what a health sector should be. Not because we don't have the money, not because we don't have the skill, but that we do not have the backbone to say clearly that that's it. And I always use this. We train our pilots in the Air Force to fly these F whatever it is. And they take a lot of time to train. And then if these people come and we're at war with Somalia, and we give them donkeys to ride on the war because you've been a very well-trained guy, and we don't win the war,
You can't blame the pilot.
surely it can't be. It can't be. And this is exactly what we're doing in this sector. All these young people, well-trained and everything, they come out, and the news is what? They're sleeping on the tarmac in Afia House. Nobody has the courage to come out and sit down with these people and say, yes, we are sorry about this, but this one we can do, this one we cannot do. Yeah. Because people don't want to use science, they don't want to use data. As I've given you the data that we have, we don't have any data on human resource. So you can't say that you cannot employ them. We don't have any data on the quality of treatment, so you can't say that we're giving Germans that. But one thing we know is that our most experienced nurses leave.
Yeah.
They don't go there to be employed as nurses. They go into old people's home, but because it's better money. Yeah. And that's it. They are going, leaving the younger ones here who don't know. That
don't
is
have
a loss
experience.
that you cannot replace. Painful truth.
Is there hope?
There must be hope. There must be hope. If somebody could be resurrected from the dead, there must be hope. There must be hope because the change that we need is not that drastic. It's doable. Yeah. And you'll see that, everybody talks about Rwanda. There's nothing that Rwanda has done which Kenya can't do better. Rwanda uses our skills on virtually everything. It's just leadership. Yeah. So if we change leadership, if our leaders change to work for this country, then the health sector will work, education sector will work, the roads will be there, and everything will be there. We are a rich country. And for goodness sake, God is an African. God is an African. There is nowhere in the world where you see this sun and this greenery.
Yeah.
Throughout the year. And yet we are importing soya from Ukraine, which is in war.
Do you think the Trump effect with the USAID may have something positive in the sense that the donor funding to healthcare systems were fragmented? Like if I'm funding TB, it's only TB. I'm not looking at the healthcare system as a whole. So do you think it's a chance to reorganize and stop the silos and, the breaking apart of the system?
As an optimist, I want to see the silver lining. The silver lining that this Trump effect is, and the opportunity that it gives. But it must not be praised for the manner in which it was done.
Of course, yeah.
And it must not be praised for the dependency with which we allowed it to happen. I'm saying that because I can state very clearly when NGOism took over this sector. As the medical officer of health in Kwale, 79, 80, I was the first African medical officer of health in Kwale. Before that, it was always a Dutch person because they have a leprosy hospital like Kalupe. So the Dutch doctor who was sent there also took care of the hospital. So even my taking over there was discussed in Holland. And Magugu called me to explain because the ambassador had called him that there's a new guy here who's disturbing the Dutch. I can make trouble. So this is what's happening. Up to that time, the only major NGO in health was the Flying Doctors, which is now AMREF. And they had very specific entry point. They had a surgeon who would come to the district to help people like us to do some surgeries of patients that we have booked. So for me, this doctor, Adam, would fly to Kwale on this one-engine plane. The day is coming, I'm told, I inform the police inspectors in Kwale town. So we close Lunga Lunga Road. And this plane, the straight area, and it comes and lands. Diani,
There was no
there was
Diani
no
at the
airport.
time.
Airfield there. Then after he lands, Shikadabu, there's a mosque there. We would call locals, we push this plane to the compound of the mosque. Then I take him in my BW Beetle, MOH's revered vehicle. And then we go. For 1 week, he stays with me and we do surgery on leprosy patients. So that was the only NGO. If you want anything called a workshop, the government built something called the Special Health Sector Training Institutions. They built 6 of them around the country that were for in-service training of health workers in every county. This business of hotels was not there. We didn't go to Diani Reef. We went to this facility in Tiwi That was for the whole of Coast. Chulaimbo here was for the whole of Nyanza. There's one in Vihiga for the whole of Western. There's Tala.
In Ukambani.
Yes, in Ukambani. Then there's one in Embu side. So they had rooms there where health workers would come in, and that is where the training was. And you can imagine, because those things were built together with WHO, you can imagine if we were spending all this money we've been putting in hotels to expand those facilities, conference facilities. Do you know how big and how complex those would be? And they were there. They were there and they worked. So the proliferation of NGOs come in after the USAID decided that government was too corrupt. So they will send all their money through NGOs. So they started, that was the creation then of the intra-health, the paths and so on, that they were getting US money as a conduit. Then they came here and they started creating their own network of NGOs. And this is exactly what Trump has interrupted. So tomorrow, I'm the chair of Intra-Health Kenya. Tomorrow, I'm presiding over the burial ceremony of Intra-Health. From that great institution that was there in this country, it's dead.
Completely.
It's being buried tomorrow. So the US policy of not working with government, it was deserved because government was too corrupt. But it created this monster of NGOs that the Trump thing is now killing. And it is the outcry from the babies of this system that is being reported. Nobody has given my side of the story. That these guys are actually killing what they created. So if you ask me, is it good for Kenya? That's a complex answer that I'll give you. Yes, it is.
The optimist
but
in
then
you says
the question is, can we go back to having meetings in our facilities? Why each parastatal has very elaborate boardrooms.
Yes.
But even Kenyatta in his elaborate boardrooms, when they want to have a board meeting, they don't hold this. They'll go to Silver Spring.
And they drive.
You go. One of the best boardrooms that I've seen is at the Council of Governors in Westlands.
Westlands,
My
yes.
goodness. I went there with all the flags there. It was like being in the UN. But they don't meet there.
No. Mombasa, Naivasha. So, at least now they come to Kisumu, Eldoret.
So you start asking yourself, okay, Trump will go with his NGOs. What will we do differently? Have we learned any lesson? None. We're just looking for another donor to start doing the same things.
To bridge the gap, as we call it.
To bridge the gap, So this is where I say that, should I celebrate? I should celebrate change that is driven locally. And that gives us a new beginning. But I don't think that we have a new beginning yet.
Is government and the Ministry of Health in this case trying to do something about the Trump and the donor exit? Or they're just...
If they are, I don't know. And even if I know, from what I have seen recently when I was talking to them through the task force, I don't think that they are capable. The capacity to think outside the box doesn't exist in Afia House. It doesn't exist in CECs that are out there in the county. No. We need radical thinking that asks the very simple question. We want to have lunch. What do we have in the kitchen? There's mboga, there's kitungu, there is that. And that's what we have. You don't start crying for chicken and insist that the lunch must be chicken, but you
Chicken.
know you don't have chicken.
Chicken.
And this is what we've been doing. We are going into things because the donor-driven projects. If you want to know how stupid we are, look at the 5-year development plan of any Ministry of Health in Africa. Look at it critically and tell me, is it different from the last one? And how much of them is describing what the donor has promised he will do? It's all donor plans.
Donor-driven.
Yeah, it's never our plan.
Even our data, we don't have our own data.
No, we don't.
I think that's why you are struggling to get the number of healthcare workers in Kenya.
Because Intra-Health has better data than the ministry. And yet they're supposed to have technical support to the ministry.
Yeah.
The only thing the ministry people want from Intra-Health is how many workshops and how many per diems. And the padiatritis is so bad that the senior people in the Ministry of Health are paid of every workshop. They don't have to go. Their money is brought to the office. So there is evidence that there is some senior people whose income from the donor money for workshops, when they counted, it was more days than there is in a year.
What?
So if you've been paid 600 days
In a year.
Yeah, and each one of them is 30,000.
Where?
But the number of days, working days in a year is not even 360.
It's not.
Yeah. I mean, why do you need DCI to come and invest that further?
It's obvious.
Yes, it is obvious.
So somebody's not working.
Somebody is not working. We know, Mercy, let's tell the truth, that Naivasha, we're doing dual carriageway now because of traffic. Mm-hmm. But just reduce the traffic from health workshops in Naivasha. And the traffic goes down substantially. The hotels in Naivasha were all built and driven by Ministry of Health.
Workshops.
There are people who now rented rooms in private houses in Naivasha. So when they go, they don't stay in a hotel. Mm. So even if you rent a house in Naivasha for 30,000 a month, but you're going there for 12 days in a month at 30,000 per day, it's still good money.
You have 11 days.
Yes. So that is exactly where we are. So if you ask me, that are these people capable of reforming to the point that they'll now say we tighten the belt? No, those guys have no belt. And you talk to them and you ask, surely, are we really working for this country? I asked, do you know how many health laws there are in Kenya? Nobody knows. The ministry doesn't know. I asked, do you know how many health policies we have in Kenya? They don't know. Because all you needed was to get a donor-funded workshop in Naivasha with a group of people for 5 days. And you go and write something. And then you also write the acknowledgement and forward for the minister.
Yeah,
then they go and sign. And then you now say you have a new reproductive health policy.
They don't even know what they signed.
If I'm lying, tell me that I'm lying. And if you're expecting that that policy is going to be implemented for the benefit of this country, it doesn't. And that's where I say that the donors have been part of it. They knew it. We knew it. I've sat with them. But they say that the only way you'll do something in that country, because we have to write a report.
To show that you've done something.
Yes. If you come with a project here and you have no workshops and per diem, nobody will listen to you. Even if it is going to save every mother and every child, it will not.
I've seen that.
Yeah. Right now, post-COVID, all the procurement and purchase of ICU oxygen, ventilators. 95 to 95% of them are no longer working.
What happened?
You see, that was the biggest opportunity for us to improve for once and for all emergency healthcare in this country. None. Because they were never brought to work.
It was entrepreneurship.
Yes, they were never brought to work.
Just so that I get my money
Yes,
from...
people had gotten their money, that was it. Yeah, they're never made to work. You go and find out all those things they were saying on Nania now has oxygen. How many of those oxygen units are still working? They're not working. The ventilators, the people who are trained in you, they are not there. They moved because they are posted to another place. None. Now, if those are supposed to be milestones of development, because you can't be starting every day afresh. So we had the opportunity to develop emergency medicine. So this country, good ICUs should be available all over, in all counties. Yeah. Is it working? Do you take your cameras? Let's go now and see if they're working. That's it. Now, there's no way you can develop health sector without continuity. Continuity of thought and principles. Continuities of action and implementation. Because it is the cumulative effect that gives you the impact. It is not one event. So, but our Kenyan leadership works on events. The minister has come and he has opened this place. And we saw it all. I've seen it all over Africa. The saddest thing in my time in working in Africa is going to Burkina Faso, going to Mali, Mauritania. And you go to this unit, I don't know, it was supposed to imaging. And there's nothing working in it. And then at the door there, you find some brass plaque. Opened on this day by Son Excellence. This. And inside is total dust and darkness. Money was spent, ceremonies were done, armies and policemen marched, national anthems were played.
For nothing.
And that is it. And this is what drove the concept of medical equipment scheme. Actually, it was my idea globally. And it was very, very simple. Behind every major hospital, there's a graveyard of equipment. Beds, X-ray thing. And my team went around and took pictures and we tried to estimate how much money has been buried in there. And it was enormous. Some of them were donated, some of them were bought, some of them, they never opened the box. Because it stayed in the corridor for so long, it was just pushed. Eventually the roof starts leaking, it's rained on. Anesthetic machine, whatever it is that. So we looked and we say that, look, how has the West
Done it.
sorted this one out? And there's a very, very simple answer. That in the West, nobody buys equipment. They lease it. They lease functionality. So they say that for this period of time, you guarantee 98% uptime and will pay for that. If it's down, you're the one who brings another one to replace it if you can't repair it within 24 hours. And that's it. So at the end of the lease, you take another lease. And it works. The big problem is that we tried designing this thing with Nyong'o. Then Macharia came in. And what is this guy? This PS.
Nicholas Muraguri.
Yes. Then they changed everything and started, number one, it was the equipment contract was not supposed to be done by a middleman. It was to be a manufacturer. Because there's no middleman who can give you something cheaper than the manufacturer. But in Africa, what was happening was that all our imaging equipment was through an Indian agent. Philips was not here. GE was not here. So you go and buy from that person, and then they don't have technicians to support it. Once they sell it to you, that's it. So we say that if you want to do this thing, do it with manufacturer GE, Philips,
Direct.
invite them to a tender. And then part of that, and I also talk to the GEs and Philips and Toshiba, and we say, you see, the problem in Africa is that you don't have your own people and your own technicians. So come to Africa, establish your own core of engineers. You've gone to Karen, the GE place, please go. I want to go there with you.
Let's go and
Right now, we have more than 50 highest trained imaging technicians for Africa. They are served from Nairobi. So they came here and created their own training lab. Do you know that MTC students in radiology, they go there for training because that's where they see the latest equipment, because they don't have them in their hospital. So they train them for the future. So they created a hub in Nairobi, because before that you had to go to Dubai or Egypt. Two, because these guys have their image to protect. Muindi atauza hiyo akishauza.
Amen.
They'll be competitive, they'll give you the best price, and they'll make sure that it's uptime, you can sue them. Then these guys come and they start changing that. The first thing they did, brought in
The middlemen.
They first of all brought in the Chinese group, Mindray. It was not in the list initially, because we had no record of Mindray in Africa. Then they brought in the middlemen. These guys were supposed to be doing the data in Kenyatta. After I've gone with you to Karen, I'll take you to near Westgate. Is it Westgate? In Westlands. GE has a nerve center for the equipment there. At that nerve center, you'll sit in a room and you'll see on the screen each machine, when it was installed, when it was opened, when it was serviced, the part that they changed, and the technician who changed it. It is there. I've asked ministers, and they say that we are ready to give this screen to every minister and every governor, so that they say this was our machine, this is it. None of them has wanted it. But you go there, you will see each one of them. Then the next thing that these people did is that they increased the type of equipment that could be leased.
Yeah, including scalpels.
Yes.
And scalpel holders, you know.
You can
lease. It's like leasing the spoons.
Yes, you can lease
spoons. No.
Yeah. You can lease tables, but not spoons.
Not spoons.
So all those ones were done deliberately. So Mashara is there, Mailu comes in with Muraguri, and that is a mess we found ourselves in. I just looked at this thing and I said to myself, one day we'll be before one God and the truth will come out. Medical equipment scheme was not the problem. It was people who now created agencies that were going to manage this thing. So all these things that are saying they've never been paid, a lot of them were those agencies that were created. They were never supposed to be there. They're supposed to be this so-called nerve center in Kenyatta. The nerve center was already established free for Kenya, for all the GE. Look, I want to go with you so that you see these things yourself. And you ask yourself, what is wrong with the health sector? It is integrity.
The leadership and governance
you
speak about.
So even right now, I was in Mandera. The only CT scan that's working there is a scheme one. because there was still some element of cover that it was there. And they came and told us that people come from over, the ordinary x-rays are not working. The CT scan is working. Yeah. So the change of mindset, because the buying and the governors didn't want it.
They didn't want
because they were now being the contracts. They were not in it. This thing had been contracted, and now you mean you'll stop me from buying MRI
and the CT, and you are taking money from source.
Yes. So that was where the problem was. And did you ever hear anybody from the ministry coming out clearly to explain what it was? No. Did you hear anybody from the professional cycles handling this thing and analyzing it? None. People just say, oh, we gave these people all a lot of money that the 7 years, the machine cost this, and this contract cost this. That contract was not just a machine.
It was a service.
It was a service. And if you look at that service of guaranteed service for 7 years, it's actually very cheap.
The only governor who opposed it, the then chairman of Council of Governors, Bomet governor, and didn't sign. And it cost him politically.
So I don't know how to answer your question on what's ailing this sector in Africa. I say that number one is integrity. Number two is integrity. Number three is integrity. And it's not just politicians, it is
also the professionals.
And that integrity is emboldened by our accepting certain things as normal. So it is normal not to go to work when you're in public service. It is normal for you to take sick off. The data shows the biggest cause of absenteeism of health workers in Kenya is the official workshop attendance.
The 600 days in a year.
Yes, 600 days in a year. You move from one to the other. In fact, you choose which one pays higher per diem.
The lower ones you give your juniors.
Yes. Or you group them, you crowd them around one place, Kisumu, so that there's 3 of them. So you sign on to all of them.
On a single day.
In a single day. So if you tell me that this thing is going to be cured by changing a minister, by doing that, that is not it.
It's not.
It's not it. And the metrics for performance have to change because there's no metrics for performance in the health sector. How many patients am I supposed to operate on as a surgeon?
Nobody says.
No. So I can operate on 0, but I'm still paid as a surgeon. I'll tell you, my old hospital, Tambweni County Hospital, when we were being sent there, you're one doctor in the whole district. You're the surgeon, pediatrician, everything. You're a public health guy. Now you'll find that there's 20 doctors. What do? Everybody does 1 month. So if you are 20, then you do 1 month every 20 months.
Once in 2 years.
Yes.
Once in 2 years.
The rest of the time, it's there. Now, the idea of having more doctors was so that you can see more people and have multiple services going on simultaneously. So that arranging those things in series and in parallel, if you did remember physics, that's exactly what they've done. We are all on duty, but some people are off. But you are off until the 20th month. And it's
taken as normal.
Taken as normal.
And if the counties complain, the unions come in.
The unions come in. And the unions come in, there's only one thing, we're going on strike. So you look at this health brewed in an African pot, where you're just throwing in kuku iko kule, samaki iko pale, nini iko pale, mboga iko pale, and then koroga. And then you taste the soup. And then you come and ask me, why is the soup bitter?
You don't even know why, because there's so too many things.
Yes. So we now sit here in the village and we want to work out how this soup will be. First of all, you don't know which taste you wanted anyway. Did you want chicken taste or nini?
Fish.
And then the donor comes, and what does the donor do? Roiko.
Ongeza hapo ndani.
Ongeza roiko. Ongeza roiko. Na taste, ongeza roiko. Does roiko make that thing taste good? I'm not an expert in kitchens, but there's something here. This is exactly what's happening in the whole continent. Leadership changes,
But the pot remains. So we need to pour that soup,
out.
clean the pot.
In fact, even come with a new pot. If it is an earthen pot, the taste is already, but you can't put fish and meat in the
so
same
you need
pot.
a new pot. Prof, what, because from the discussions here and all the many ones that you've given, you're blunt, you're fearless, you say it as it is. What makes you not fear telling off even presidents?
One is that I'm in my own turf. I only comment on health. So I'm not going to comment on who was in ODM or Roseware. That's their problem. And in health, I'm safe in my knowledge. So it's my turf. And I'll say it, I'll defend it, I'm trained in it, I'm experienced in it. Challenge me on that turf. The second one is that I'm at an age now where there isn't much you can do to me to hurt me. I'm mature. So there's really nothing to fear if your country trained you in this field and you apply what you're trained on. It's logical. The third one is that it is never about individuals. It's about our country. It's about our continent. I'll talk about our country and our continent. And you can't take that away from me. You can't make me a European. You can't make me an American. You can't stop me from being a villager here. So I have a right to comment on that thing. And the final one is that it's easier to defend truth than to defend lies. Because if you're defending lies, then you have to remember what the last lie was. And remembering the last lies can be very difficult. But the truth, there it is, trains. That added to the fact that I've been lucky not to depend on government for my growth. Yeah, it's been personal. In fact, government made me leave the country.
And wanted to sabotage you even when you're out of the country.
Yes. Government made me leave the country, but I served my government and my country. I believe that I have a record of service. That whether you go to Washington, D.C., whether you go to Colombia in South America, whether you go to India, the people that I've worked with, they tell you that, yes, he delivered. I'm one of the few Africans who have been assigned to assess the whole of India's health system. And I go to each one of those states, from Assam there to here. And I brought a report that made the World Bank stop a $1 billion project in India. Because they had lied and said, this is it. And people lost jobs. I believe that probably I'm the only Kenyan here who has received life achievement certificate in Nigeria and South Africa and here, purely on the work that I do. And I also believe that I have a unique insight because I've been on the private sector, I've been in the public sector, I've been in academia, I've been in the NGO side, then I've been on the global side. I've sat in some of the most important decision-making fora in my lifetime. So at least historically, I have some things inside my head that I can connect. And then finally, the good Lord has not silenced me. I've not had a stroke yet. So
Why are you saying yet?
I've not been stopped by infirmity. Yeah. So that's it. That's it. It's a very, very simple thing. That in retirement here, I choose what I do. I'm invited to many things. I don't go to some. I choose what I do. Some of them I do virtually, and now virtually you can, from here can give a lecture at Harvard.
Yeah.
So I've kept my linkages. I'm still out there, but I've also kept my sanity. I hope so. And most important is my integrity. If anybody finds in my track that there's somewhere where I'm misadvised or I procured wrongly, let them put it there. Because there's something that is eternally gratifying when you say, I've done it. And you just come to the village and just rest here.
Of the many awards and recognitions, what are you most proud of?
It's not a difficult choice for me. I think that I'm most proud of the things that I've done in my community here. Because eventually East-West home is best. The Sagam Community Hospital, the full name is Gordon Rogo Memorial. It was in memory of my father, who spent all his life as a teacher. And it was inspired by two events here in the village. One was my grandmother, Kezia. She was in her 90s. Our health center is near Magoza, also home up there. And she went there with her nan. They said that there was some infection in the lungs, but we cannot give you medicine because they wanted to give him injection of penicillin. They said that since children die more, we cannot give you. We only have enough medicine for your grandchildren. So she said, thank you very much. And she came and covered herself in the blanket here and died. Then the other one was where the land is. The old man there fell from bed. He was in his 80s and broke his hip many years back. So I came and I was coming home and I found him there. My mother told me that there's this mzee here who throughout the night cries. Go and check. I went and checked. So I carried him to Siaya. And I was a lecturer then. I found some people that I taught there. They said he's okay. We left him on the floor because the beds were full. And when I went back 2 weeks later, he was still on the floor. They're not even giving him Panadol. So I said, if the government can do it, I'll do it. That's it. So we just started. I cleared the bush, put up the thing, and nearly 30 years later, it's running.
Khama Rogo is a professor of obstetrics and gynecology and Kenya's first fully trained gynecologist. He has worked with the World Bank for 21 years. He has met presidents and many world leaders. He has been in forums whose decisions shaped the healthcare of countries. But it is this Sagam Community Hospital, a memorial to his father Gordon Rogo, that is his proudest achievement.
So you look at a place here like Game. I think we can run 10 medical schools.
Here.
Yeah. All of them professors here in Game. But have things changed for the people of Game? They're still the same as the people in Tana River. Yeah. Why? Because we have not asked, how do you apply these skills and knowledge to change your community. We joke here that if you're in a helicopter up there and you drop a stone, it will fall in the head of a professor. Yeah, it is true. But that professor, I did some study some time back on Siaya County. And I found that the concentration of pit latrines is inversely related to the number of professors.
The more professors, the less the pit latrines.
So there can be three reasons. One is that they're not pits, so they now have these flashed ones, which are in the house, which we found was not true. Yeah. The second one is that they don't come home long enough for them to feel like going to the toilet. Which is true.
Which is like a few hours.
Yeah. So you you are at Imperial Hotel, and then you come and see your mother and leave.
And then you go away.
Yeah, and then you go away.
That is so sad.
My friends are waiting for me. And the third one was that they've actually moved from normal diet to astronaut diet. You know, astronauts, when you're out there, you don't shit.
Yeah.
They give you diet which you digest everything. And my hunch is that they're not eating that way, because I see them with nyama choma and ugali and samaki. So out of those three, the most plausible thing is,
they don't stay long enough.
if there's places in Africa that if we gave everybody who's going to school or is holding a job in Nairobi or America from there, and there were 5 amp torch, the place would be lighted more than the streets of New York.
Wow.
But the places are dark because these guys have never come back home as torches. When they come home, they're not a torch, it's switched off.
Is that part or the reason why we have few philanthropists from Africa?
No, because part of the thing is that actually we have more philanthropists in Africa than anywhere. It's just a definition of philanthropy. Yeah. If you work out there with in these people's country, as I did for over 20 years, and you look at what you do with your salary.
Yeah.
Yeah. I mean, half of it goes into philanthropy before you, but it's not called philanthropy.
It's not called philanthropy.
And it is not organized.
Almost daily.
Every
daily,
day.
yeah.
Every day.
So an American, I'm working with him, his salary can plan holiday with it. But to me, there is this funeral there is that and that. So philanthropy is just definition and organization. If we organize this money and we put it together, it will change everything. Do you know the amount of money we collect for funerals?
It's a lot.
Every week.
It's a lot.
Yeah. And none of that is credit. It is cash. It is cash. So we are the original philanthropists, traditional philanthropists. The other thing, and this is I think what you are referring to, that we don't have the Bill Gates and so on foundation system. The foundation system is not strong in the rest of Europe and the rest of the world. It's strongest in the US. And the reason is very, very simple. That the tax system is structured in a way that allows you to put that money in philanthropy in lieu of giving it to the tax man. If you ask Kenyan today, as we increase their taxation, whether we should give that money to the government or put it in some foundation, they'll put it in the foundation.
We'll put it in the foundation, definitely.
Yeah. So their laws allow that. And that's why everybody who's rich in America puts a foundation. It is off tax. So it is recognized. We don't have that here. If we were to be claiming everything that we produce for harambes and funerals, I mean,
Yeah.
they would actually refund us. Yeah. So again, that is also another governance thing. That if we are so philanthropic, why don't we organize it so that it is channeled better, so that it is recognized by the tax system and so on, and then it will start growing. I know people in the religious ministries say that it is a calling. I believe that it is an even higher calling in health. And when we were being trained, we were never trained to be rich. We were trained
To serve.
to serve. And I say, it's much, much better. I'd rather be unhealthy, living in a healthy community, than be one healthy guy living in a community of sick people. This is what drives me in Sagam. That when people around you are healthy, they can take themselves, they can take their kids to school. Life is much better for everybody.
The community is even happy because you meet everyone and you have good things to share and talk about.
Yes.
Yeah.
And I believe that that is the quality of life changes for everybody. You come loving to be in the village. Yeah, I'm not afraid of being in the village.
And walking around.
No, I just walk. Yeah, because after all, they saw me walking barefoot with no surwali. So what's so great? Because I went and got a degree?
No.
Do I change? No. It's just you.
You're still the son of the
You're
village.
still the same son of the village. Yeah. So the joys of life as you grow older stop being your material possessions. They start being the relationship that you have with people, starting with your own community. And if we mentor our young people to know that actually life is very short. 70 years is not a long time. Yeah. Right now I'm being interviewed here as an elder. Me, I still see myself as a very young guy who can cause a lot of problems. Yeah. And that's it. That's what we don't see. Yeah. That just the other day we were the hot heads. Now we're supposed to be the ones who are being consulted to tell what has changed within that. Nothing much. And this is what Africa has to know. I think that the other people are developing because they love their country, because they work for their people. Africa is not moving because I don't think we love Africa. Because we want money so that we can escape.
We can go away.
So that you can take your kids to those schools there. So that you can go and be treated out there. And it becomes an exclusive club. People whose kids are educated there, they can go for treatment there, and you here, you're sitting. People don't remember that when the new Kenyatta Hospital was opened, that block, the top floor there is a presidential suite.
Ward 10.
Yeah.
Floor 10. 10th floor.
And that it has a helipad.
It has a helipad, yeah.
On top. So it was built for the president to be able to go to Kenyatta. There is no president who has ever stepped there.
Not even Moi.
No.
It's only Ngilo tried when she was Minister for Health.
No, never. So it even had a room for the security guys. So that one tells you that there is something that is not with us. It's not inside us. And health, you can't give health to people if it's not coming from the heart. It has to come from the heart.
Reflecting back on our days spent with Professor Khama, it was truly learning about health brewed in an African pot. We learned from his vast wealth of experience, from his work in the global stages championing for health, his current work with the community through Sagam, his soybean farming ventures, and finally, entrepreneurship on our way back to Kisumu, where we stopped at his beachfront resort to enjoy fresh fish from Lake Victoria.
When all is said and done, Professor Rogo says there are two things that relaxes him. One is being at home in his farm and being one with nature, and two is being by the lakeside enjoying a plate of tilapia.
Dr. Mercy Korir for Willow White Coat Diaries.